may contribute to bone loss, like hypogonadism, reduced production of IGFs, and myopathy with increased risk of falling. So all this will increase the risk of fracture, and added to that is the disease activity that the steroid was giving for, the physical disability that comes together, and elevated inflammatory cytokines. And this is mainly, of course, we see that in rheumatic diseases. So if patients receive glucocorticoids in other forms, like intermittent or alternate days or pulse therapy, with intermittent there is less effect. With the glucocorticoid on alternate days, it may preserve growth in children, but it does not prevent bone loss. With pulsed glucocorticoid, there is less effect on bone density compared to continuous treatment, but there is increase in the risk of osteonecrosis. But don't forget that steroids, they have protective effect because they suppress the underlying disease activity, and this will protect the bone from bone loss. So it's not all like doing harm for that. Now, there are a lot of risk factors that are related to GIO. Some of them related to the steroid, mainly the dose and the duration. Some are related to the underlying condition. And mainly we always say rheumatoid arthritis is the worst in the effect on osteoporosis. And there is, risk related to osteoporosis itself. Risk factors like the age and being post-menopause. When patients take steroid, they lose bone maximum in the first 3 to 6 months. They lose even about 20% of their bone. And then it reached like a plateau or a slow decline. And then when steroids are stopped, there is a gradual increase in bone density, which may take up to 6 months or 1 year. And this is if patients stop treatment, which does not always happen. The risk on fracture the risk of fracture, of course, is related to dose. So the doses for certain 7.5 and more, they cause significant bone loss. There is some evidence about bone loss with smaller doses, but it's not very strong. But it's mainly the dose with increased risk of fracture, of course. So the risk, again, increase according to the dose. If you look to electron microscopy in the bone, that is for these patients, you will see that there is low trabecular number and plates, increased trabecular separation. So the increased risk of vertebral fracture is because of the greater effect on trabecular bone rather than cortical bone. And there is, of course, mainly marked depression of osteoblasts, whereas in the usual primary osteoporosis, the postmenopausal, there is very little decrease in bone formation, but there is activation of bone resorption. So it is not the same mechanism like in postmenopausal osteoporosis. Now, the fracture risk in patients on steroid, when you compare to patients who are not using steroid, happens mainly because it alters the bone density fracture threshold. So these patients, they tend to fracture at a younger age, at a lower baseline femoral neck and lumbar spine bone density, with less number of prevalent fracture. They have much more risk of a new vertebral fracture, and in general, the risk of fracture increased by more than 6 times. Now, there are some issues in diagnosis and management. First of all, if you have access to trabecular bone score, you have to use it because it is superior, like in primary osteoporosis, it is superior to DEXA scan. Also, if you are using the FRAX tool in these patients, you have to make adjustment for these patients because the FRAX tool may underestimate the actual fracture risk in people on high doses or overestimate the risk in people on lower doses. So there is, like a protocol on how to adjust that. So you add it to the risk, you increase by 15, 10, 25% according to the age of the patient. The studies on GIO, on medications, the number of fractures in these medications are small. So the analysis, it had very little power to detect difference in the relative risk of fracture in these studies. The treatment studies was relatively short. Maximum probably is 2 years in these studies. So the certainty of evidence based on any medication that you are using in GIO is either low or very low. You don't have very strong evidence for all medications. Always, of course, we'll not go through that, the non-drug treatment in these patients. At the end, we will go through the guidelines. But first of all, these slides will just make you understand more the guidelines and how they are based from the beginning. So, and calcium, vitamin D, you will find it in the guidelines, the doses. I don't think we have to discuss this. What about gonadal hormone replacement? So patients, they can have hypogonadism because of steroids. So do you treat it? Do you depend on that to treat osteoporosis? Of course, in females, the WHR trial exposed the risk of long-term HRT, so we are not using it because there is benefit, but the risk is more than the benefit. In males, there is no strong evidence to support that the use of testosterone is beneficial in fracture reduction. So until now, it is not used in this, even with hypogonadism. So that's why if you look to the list that is put from in the ACR guidelines, you will not find a space for HRT, either in men or in women, because the evidence is not very strong. So now we'll go through the main medications in GIO. Bisphosphonates, of course, always when you have a lot of medications, a lot of studies, it's better to go for meta-analysis or Cochrane system review. They will give you the summary of all the studies. So according to the Cochrane review, at that time, it was done on 18 trials with more than 1,500 patients. So there was reduction in vertebral fracture versus placebo, with improvement, of course, and there was risk of non-vertebral fracture risk, which was not statistically significant. So the bisphosphonates in general, there is a good evidence that they decrease vertebral fracture, but not non-vertebral or hip fracture. So, and it's not always because the drug is not beneficial in this group of patients or in this type of fracture. It's because the hip fracture usually occurs in much severe cases at an older age. So if the original number is not very high, it's difficult to get a statistically significant result with that. So, but it doesn't mean that it doesn't work. Zoledronic acid was compared to risdronate, and of course it is superior as expected. What about denosumab in these patients? Denosumab is superior to risdronate, just like primary osteoporosis, for increase in bone density, and the vertebral fracture increased after stopping. This is a very important point when you stop it. So if the patient can use it, it's better to use it. It is superior to bisphosphonates. But if you stop it, just like primary osteoporosis, after 7 to 9 months, you should expect increased risk of refracture. So you have to give something else after that. What about regarding teriparatide? Again, it decreased the incidence of vertebral fracture, but there is no evidence that it decreased the hip fracture. And the good thing about teriparatide, that bone density continues to increase even when the drug is stopped. So this is very important, although we always say still that you have to give another treatment for that. And the appealing point of teriparatide is that it is the only drug that reverses the pathophysiology of steroid. Because as we mentioned, steroid, they decrease bone osteoblast or bone formation. So the only drug which antagonizes this is teriparatide, not like the other medications which mainly work on anti-resorptive. So they are better used in postmenopausal women. Also, in patients who develop AFF or atypical femoral fracture, most of these patients, they are on steroid. And we'll not go through the AFF and what is it. But just to know that if you have patient with AFF, mainly it means frozen bone, the underlying pathophysiology. So the best treatment, just like primary osteoporosis, is to give teriparatide in these patients, although it's not approved either in primary or secondary osteoporosis for this indication, which is AFF. And it should be, there are a lot of expert opinions both in primary and secondary osteoporosis that teriparatide should be considered as first-line therapy for those at very high risk, like very old patients who starting very high dose of steroid, multiple previous fracture, very low initial bone mass, less than -3.5, and this is of course in patients in primary osteoporosis. So probably -3 is indication to give teriparatide in GIO. And it may be even cost-effective in these patients. It is superior to alendronate, of course, as expected. in decreasing vertebral fracture and non-vertebral fracture. Regarding romosozumab, there is only one ongoing phase 4 trial comparing romo to dino for the treatment of osteoporosis in long-term users. We don't have the results for that yet. What about patients with GIO who have been treated for a reason with bisphosphonates before? Here, teriparatide is superior to denosumab. It increased the bone density in all sites, not like denosumab. So it is superior in patients with GIO who have been treated with bisphosphonates in the past. Also, the other thing is that the therapeutic effect of denosumab in patients who are previously treated is blunted, but with teriparatide there is significant increase in the bone density, as we mentioned. So it is superior at all levels. Now we go to the guidelines, which were published in 2017, and then there were some update in 2022. So first of all, you have to get familiar with the terms that have been used in these guidelines. And so they are a little bit different between the young and the older patients, which is 40 years of age, more or less than that. So major fracture is the same. In the clinical fracture risk assessment, no fracs, of course, for the younger patient. So the same factors, apart from no fracs used in younger patients. Also, again, in the follow-up, you use fracs and bone density in older patients, but no fracs in younger patients. And the fracs correction is not applicable, of course, in younger patients. So you start with risk stratification. Any patient who is planned for a long-term steroid, you start with bone density, which is recommended to be done within 6 months of starting the steroid therapy, and then every 1 to 2 years, therefore, when patients on treatment. So it's always get used to doing bone density initially when you see the patient and decide to give them long-term treatment. These are the clinical risk factors that you have to consider during the assessment. Now, regarding the categories of patients, it can be either high risk, moderate risk, or low risk. So there is again a little difference between the young and the older patients. In younger patients, you use the same risk factors: prior osteoporosis fracture, steroid dose more than 30, or cumulative dose more than 5 grams per year. But of course, there is no space here for bone density or fracs tool in younger patients. If patients they have this risk factor, the younger one, they are considered high risk. If they don't have it, then you will go to do bone density, and then based on that you can categorize the patient either moderate or low risk. With the older patients, you will just use fracs for the moderate risk category. Now the younger patients, they are considered moderate risk if they continue treatment for more than 6 months, more than 7.5, and they have PIP or spine Z-score less than 3. Or if they have rapid bone loss. If you do DEXA scan for them, it's okay, and then you repeat it. Sorry. And then you repeat it, and there is significant bone loss, more than 10%. This is moderate risk. Any patients who don't have any of these factors, they are low risk. Probably it's difficult to remember this table unless you get used to it, but it's better to put it always in your pocket so you can use it when needed. When you look to the recommendations of the medications, you will find strong recommendations and conditional recommendations, and this is based on the evidence that is available. So of course, always it's more favorable drug. I mean, this is what means by strong recommendation. Now, regarding the treatment, the only difference here is that in younger patients, there is no strong recommendation because the evidence is not strong like the older patient. Of course, because the older patients, they have higher risk of fracture. So in older patients, first line, strong recommendation for oral bisphosphonate and conditional recommendation in other medications, and against ROMO or SERM. In younger patients, there is no strong recommendation, but it's conditional recommendation for all medication. And against, again, ROMO and SERM. So just, classify it like this, and then look at it like this, because it looks confusing in the beginning. And then you will remember. So with or against. To make things easy, I tried just to squeeze the risk stratification and the treatment recommendations in one slide. So maybe it's a little bit easier if you just can capture it and then you can use it. But of course you have to go in details first in the guidelines that are published. So this will just give you a clue what to do, because otherwise it's easy to forget. What about sequential therapy? It's like primary osteoporosis after teriparatide or denosumab. If you stop, there is always bone loss. You don't stop. After bisphosphonates, okay, you stop, you take drug holiday. So the same here applies for sequential therapy in patients on steroid. So if the glucocorticoids are stopped and the patient, you have to reassess the patient, are they low, moderate, or high risk? So if the patient is at low or moderate risk, you stop bisphosphonates. You don't need anything after that. But if they are on PTH or for some reason Romo or Dino, these medications you don't stop, and of course you don't continue for a long time after that because you stop the steroid. So you give it like for 1 to 2 years, just to make sure that they don't lose bone after that. Patients who remain at high risk, they continue treatment therapy or switch to other treatments. You have to continue treatment even if you stop the steroid. And using 2 different osteoporosis medication at the same time is very limited. Probably the best evidence is using teriparatide with the denosumab. This is the best one. What about follow-up treatment? How do you define the failure of treatment? The failure of treatment for older patients, if they fracture 18 months or more after beginning treatment with oral bisphosphonate, or if there is significant decline in bone density. So you have to know what is the definition of fracture, of failure of treatment. So if this happens, you will switch to another medication. So if this happens, you have to switch to either teriparatide, denosumab, or Romo. Okay, if you orzoledric acid or Romo if you are stuck, which is, I don't think it will happen. In moderate to high fracture risk, if moderate to high fracture risk persists after bisphosphonate therapy, in these adults who are continuing, you have to continue treatment, of course. Whatever treatment you choose at that time, but you have to either continue bisphosphonates or switch to other medications. You have to be careful. Okay, خلاص, one slide only. Regarding the vertebroplasty or kyphoplasty that has been used in patients for chronic spinal pain, if they have fracture, we always say that even primary osteoporosis, they have risk of refracture. But in GIO, they have more risk of refracture, 2 times more increased risk of refracture in these patients. So you have to be careful when you do this procedure. Thank you.
Thank you, Dr. Basma. So our next speaker is Dr. Faiz Al-Harthi. He is a consultant rheumatologist and section head rheumatologist and fellowship program director at King Abdulaziz Medical City in Jeddah. Dr. Harthi, he is going to talk about can we reverse osteoarthritis. Dr. Harthi, the floor is yours.
السلام عليكم ورحمة الله. صباح الخير. First of all, I would like to thank the organizing committee and the scientific committee, Dr. Hanan Al-Rais, Dr. Fahad Al-Anizi, for their kind invitation for this very enriching conference. I was assigned to talk about very important topic and challenging and with lots of unmet need in our daily practice, which is osteoarthritis. Can we reverse osteoarthritis? This is a very important question. Slides, okay. So, what are the objectives of my presentation? First of all, to review the new promising disease-modifying osteoarthritic drug like what we have in rheumatoid arthritis. Other thing is to answer a question: can curcumin and boswellia serrata improve osteoarthritis symptoms? Are intra-articular steroids and hyaluronic acid injections not better than placebo? Can steroid injection increase cartilage loss in osteoarthritis patients? What about the role of stem cell therapy and platelet-rich plasma on osteoarthritis? So why do we care about osteoarthritis? As we all know, osteoarthritis is the most common arthritis disorder worldwide. So it is, we have more than 500 million globally, and about 15 to 20% of people above the age of 45, they have an element of osteoarthritis. And it costs about 100 billion annually, and more than 900,000 hospitalization. The burden, as I mentioned, the most common cause of arthritis. The third most likely rising condition after DM and dementia, and it has a significant disability. It affects quality of life of lots of population, and marked unmet need in this disorder, not like other disorders like rheumatoid arthritis or SLE. We have very effective therapies. In the past, we thought osteoarthritis, it is just a degenerative disease. It is a mechanical disease. But in fact, we have more than that. So we have a mechanical effect. We have an inflammation ongoing. In the same time, we have a tissue repair, and all of this will cause pain. But compared to rheumatoid arthritis, this is very slow and it takes time. Here, just a touch on some promising new disease-modifying osteoarthritis drugs. These medications, some of them, they are in phase 1, phase 2, or phase 3, including the wingless integration or Wnt pathway inhibition, and nerve growth factor also inhibition, because this is important for pain propagation. Other important target is fibroblast growth factor receptor agonist, which may lead to cartilage regeneration. Also, Adams TS5 and CCL2, CCR2 molecular pathways, they are very important also for pain and for cartilage degradation. Osteoarthritis pathogenesis and targets. We have here, as mentioned, targets in mechanoinflammation, targets in tissue inflammation like Adams5 and CCL2, targets on tissue repair like the Wnt antagonism, and we have also targets like of regeneration of the cartilage like the FGFR3 agonist. Just here, we have some repurposed and investigational disease-modifying osteoarthritis drugs. So the three endotypes targets either the cartilage endotypes, the bone endotypes, or the synovium endotypes. In the graph on the right-hand side, we have the knee joint. We have the repurposed agents. That means agent we used before in other disorders, and there are some studies on patients with osteoarthritis, like bone-driven cartilage, like teriparatide, zoledronic acid, denosumab, vitamin D. In synovitis, methotrexate was tried, hydroxychloroquine, etanercept, and even tocilizumab was tried, and also some even anti-diabetic medication were tried in studies, but there was no really significant or promising outcome. On the right-hand side, we have maybe some promising investigational medications, including bone-driven endotypes, synovitis-driven endotypes, cartilage-driven endotypes, including cathepsin K, also including fibroblast growth factor, TGF-beta, and others. What about targeting inflammation? Wnt signaling pathway plays an important role in the joint, in synovitis, joint capsule damage, cartilage degradation, chondrocyte hypertrophy, and meniscal degeneration. By blocking this pathway, this may really decrease the inflammation in the joint and decrease the pain and the progress of osteoarthritis. One famous molecule, the most famous molecule in this pathway, is loricifivint. This drug was tried in multiple trials, looking for WOMAC pain. One famous study, more than 400 patients, intra-articular injection of 0.07 milligram of loricifivint resulted in numerical improvement in pain and function, and as well medial joint space width. So maybe this is a promising future drug. Also, targeting nerve as well is very important. By blocking nerve growth factor may also has a role in decreasing the pain. One famous example is a drug called tanezumab. Tanezumab was studied a lot in the past decade in musculoskeletal pain, including osteoarthritis. We have here one study showed that tanezumab decreased the WOMAC pain, WOMAC physical function, and patient global assessment of pain if given in 5 or 2.5 milligram. However, with regard to this molecule, there was a new studies in 2022 comparing tanezumab to this is controlled trials, 1 year, comparing it to non-steroidal anti-inflammatory drugs. It decreased pain, but there was what they observed, there was rapid progress of osteoarthritis, and patient developed damage and ended by knee joint replacement. So the authorities in the EMA and FDA didn't authorize this drug for the treatment of osteoarthritis, unfortunately. Targeting bone, also unimportant, like TRKA, one studies, although this is small and there are other studies, showed a single intra-articular injection. The pain improved after 4 to 5 weeks compared to placebo. Here other pathways, the ADAM TS5 and the CCL2, CCR2. On the left-hand side, the ADAM TS5 molecular pathway has an important major role in the aggregates in cartilage degeneration. So blocking this molecule may slow and reduce the cartilage degradation. On the right-hand side, also CCL2, CCR2 molecular pathway inhibition may reduce the pain and inflammation in the joints. What about targeting cartilage? Targeting cartilage, this is also very important, like fibroblast growth factor agonist. In a famous study called the Forward trial, this is a 5-year-old trial. This study, they give a molecule called sperfermin, and they looked for change in the thickness of the cartilage and the pain over 5 years. So here we can see the study was initiated 2019, and then also in 2021 they did a post-hoc analysis from the study, and they found in this group of patients, more than 500 patients, that there is a 50% improvement in the WOMAC pain at 2 years and was maintained after 5 years. And even, as we can see in the graph in the bottom, even in the subgroup at risk, it was maintained. So the forward study was also promising, and this sperfermin may be a potential target in the future for cartilage regeneration and buildup. What about intra-articular corticosteroids? It has been shown, and we are using intra-articular corticosteroids in our daily practice and our colleagues in orthopedics. Many studies in intra-articular steroids, including these studies, showing that repeated intra-articular steroids after an initial dose, then you can give either after 12 weeks or 16 weeks, whether or you give after 20 weeks or 24 weeks, the pain relief was maintained. But the question is still there. Are they effective? We have here, this is meta-analysis recently published comparing intra-articular steroids to either hyaluronic acid, NSAID, placebo. Probably it is effective in the short term, like less than 6 weeks. However, sustained efficacy of repeated injection is still not clear. What about the safety of intra-articular steroids? As you know, all of us are using intra-articular steroid in osteoarthritis patients. So many reports over years about with and against. So we have, like in 2017, 2019, some studies showing that it may increase cartilage thinning. Also, it may increase the risk of knee replacement. However, recent studies, as we can see, in 2021 and 2022 showed there is the progression of osteoarthritis after intra-articular steroids was not observed. Even joint space narrowing, medial joint space width, there was no change in this study with like 773 in the glucocorticoids arm and the hyaluronic acid 200 patients. Also, the hazard ratio for risk of knee replacement in glucocorticoids compared to hyaluronic acid was 0.75. It was not increased. Another new studies, also for 5 years, do glucocorticoids injection increase the risk of knee osteoarthritis progression over 5 years? This study was also last year in arthritis and rheumatology. 564 patients, no significant increased risk of total knee replacement or radiographic worsening, but we have to use it widely. As we know, we don't use more than 3 injections per year. Also, intra-articular steroid compared to physiotherapy. This study in New England Journal of Medicine 2020, comparing to physiotherapy, it showed that physiotherapy after 1 year may be better than intra-articular steroid. What about visco supplementation? Here, just I want to share with you a big meta-analysis, and it was published last year in the BMJ, including 24 large trials, around 9,000 patients, and they found that there is small reduction in knee OA pain compared with placebo, but less than the minimal clinically important difference. So the difference was minimal. And even side effects, serious side effects were more in the hyaluronic acid, 3.7% versus 2.5% in the placebo group. What about herbal medication, herbal extract? Curcumin and osteoarthritis. Efficacy and safety of curcumin alone in alleviating pain and dysfunction for knee osteoarthritis. This is a systematic review and meta-analysis of randomized control trials, 14 studies, 1,670 patients. They found, as we can see here, in the left-hand side, WOMAC pain improved. Also, the WOMAC function improved in the short term. Interesting, there was no adverse events of this molecule. As you know, this is a traditional molecule. So, curcumin is a potent antioxidant and anti-inflammatory, blocks chondrocyte apoptosis, expression of cyclooxygenase prostaglandin A2, primarily recommended as a symptomatic short-term and medium-term adjuvant anti-inflammatory therapy. The most researched daily dose are 1,000 to 2,000 milligram per day. Further research is needed to determine the preventive role in osteoarthritis as well as optimal therapeutic dosage. What about boswellia? what we call Luban. Boswellia serrata, does it improve osteoarthritis? Boswellia serrata is a potent anti-inflammatory, anti-arthritic, and analgesic agent. And that may be a drug for osteoarthritis as a pain reliever. Formulation administered as monotherapy are significantly more effective than placebo, relieving the symptoms of knee osteoarthritis. These formulations have a comparable efficacy profile to NSAID treatment with significantly fewer adverse events. So there are no adverse events observed with this. Here we have this study, meta-analysis, showed that curcumin and boswellia could reduce the pain and improve function in osteoarthritis with reducing risk of adverse events. Further research with large and long-term studies are needed. What about platelet-rich plasma in osteoarthritis? This is a study in JAMA 2021, effect of intra-articular platelet-rich plasma versus placebo injection in pain and medial tibial cartilage volume in patients with knee osteoarthritis, the RESTORE randomized clinical trial. Participants recruited from community in Australia, 12 months follow-up, 3 weekly injections compared to saline, 144 patients in each arm. Patient and providers were blinded. So the pain, and we can see here in the primary outcome, there was no difference in the pain. Secondary outcome, slight improvement of function, but not that really important. So platelet-rich plasma, so the effectiveness of leukocyte-poor platelet-rich plasma. This is another study in Bone Joint Journal, a double-blind randomized controlled trial of 3 groups receiving either placebo injection, platelet-rich plasma, or injections. A total of 100 patients were recruited. The follow-up was 12 months. No evidence that single or multiple platelet-rich plasma had any additional benefit compared to placebo at 12 months. What about stem cell or mesenchymal stem cell therapy? As you know, this is very growing in the field of medicine. The source usually either from the placenta, bone marrow, or adipose tissue. Mesenchymal cells has many effects like the trophic effect, anti-scarring, anti-apoptotic, angiogenic, and mitotic. It has also immunomodulator effect in the T cells, cytokines, B cells, macrophage, dendritic cells, neutrophils, and natural killer cells. In addition, it has an antimicrobial effect as well. So, autologous cartilage implantation in clinical practice, we have some phase 1, phase 2 studies, but radiographic osteoarthritis is a predictor of poor outcome. Mesenchymal cells are able to differentiate into multiple mature mesenchymal cells, including chondrocytes, and can form hyaline cartilage-like dish. There are small phase 1, phase 2 trials suggest relative safety. Does it cause cartilage in osteoarthritis? Yes, it may cause cartilage regeneration, and it is a potential mechanism as an immunomodulator in the joint. And it may be a future really promising in patients with osteoarthritis for repair of cartilage.
Dr. Harthi, time is up.
So, the last 2 slides.
Okay.
So, to summary and conclude, osteoarthritis is the most common joint disease and is a major cause of disability and impaired quality of life. Worldwide, there is still significant unmet need for therapeutic in osteoarthritis among all MSK disorders. Intra-articular glucocorticoids work for short term and probably without significant increased risk of total knee replacement or radiographic progression based on the latest meta-analysis and studies. Hyaluronic acid and platelet-rich plasma are both minimally effective based on the recent evidence. Curcumin and Boswellia serrata may improve osteoarthritis symptoms with reduced risk of adverse events as a symptomatic treatment. Still, cell therapy is a potential immunomodulator and may promote endogenous cartilage regeneration for the future. Novel disease-modifying osteoarthritis drugs that both inhibit structural disease progression and improve symptoms are in the horizon. Thank you so much for your attention.
So thank you so much, Dr. Faiz. The next presentation, advancement in treating patients with uncontrolled gout. And the speaker is Dr. Mohammed Al-Attar. Dr. Mohammed, he is the consultant rheumatologist in Hada Armed Forces Hospital. Also, Dr. Attar, he is the member in the scientific committee of the rheumatology program under the umbrella of Saudi Commission for Health Specialties. So I would like to welcome you again, Dr. Mohammed, and the floor is yours.
طيب. السلام عليكم ورحمة الله. صباح الخير. So hope you are all enjoying your time. I would like to extend my gratitude to the organizing committee and actually congratulate you. You actually exceeded the expectations, so I have to say that before I start. So my talk today is going to be on gout. And it's always a challenge to talk to a group of rheumatologists about gout because, I mean, you guys probably treat gout better than I do. However, there are some things maybe that we're going to re-establish and see how we can go through with it. So I'm going to actually start by the opposite. So I'll just give you my take-home messages, and then we'll walk our way through and try to conclude with the same conclusions. So hyperuricemia is necessary, but they are not sufficient to cause gout. And difficult to control gout doesn't mean resistant disease, and I'm going to show you how. Allopurinol is not nephrotoxic. And appropriate urate-lowering therapy is important because you can remove the deposits and hence you're going to stop the flares from occurring, hopefully. And treat to target is an achievable goal. It's something that we can do. It's not like a myth. So let's go through with it. So if you know this, you know how to treat gout. Anyone knows how to treat gout. You have hyperuricemia to a certain degree that is exceeding the saturation point, and then after that you'd have some deposition that occurs in the joints or in the soft tissue. Later on, this is going to result in a way into self-resolving flares that usually are recurrent. And then if you use an appropriate anti-inflammatory, you're going to abort the inflammation. Urate-lowering therapy, you're going to stop it from happening in the future. So it seems to be easy, right? Like everyone should know it. Family physician can treat it, internist can treat it. However, for us rheumatologists, I think each of these boxes have like some intellectual and practical interest for us. So let me just go through with it. So when we talk hyperuricemia, we do understand that it majorly happens because of the kidneys. What happens basically is that the renal reabsorption gets high based on this receptor, the urate1 receptor. So everything gets filtered in the kidney and goes out, and then except the uric acid, you get to reabsorb it, except about 10% that goes out with the urine. This is the major way where we're getting the uric acid from. Then the GI excretion. So back in the days, we did not put a lot of weight. Now we understand that it has a bigger proportion than what we thought. So a specific transporter, a polymorphism to a specific transporter can dictate which patients are going to excrete more in the gut and which are not. In a way, it kind of dictates who are going to have hyperuricemia and who are not. This is like a new exciting knowledge for all of us. And then there was multiple GWAS studies did show that there are some enzynopathies that we don't really know. It's not fully explored, but it has like a strong association genetically. Another important factor that we used to think that why women premenopausal don't have gout, right? And then we thought, well, it's easy because they have estrogen. Estrogen is a uricosuric agent, so that's why. Well, it wasn't really true because like estrogen would account only for 0.3 milligram per deciliter, which is supposed not really to be protective. There should be another factors that we still are going to explore and find out. Obesity, obstructive sleep apnea, other part of the metabolic syndrome, all of these things do happen with hyperuricemia, and we tend not to know why they do happen. And then there are some theories that because of these soluble crystals, this is why we're having these other comorbidities. Now, fructose does increase the synthesis of uric acid, and then other agents like alcohol and some drugs also contribute. But all of them, they contribute to a certain degree. It's not like super high. So it does tell us that serum uric acid does predict the likelihood of initial gout. This is like a well-known knowledge for us. And this is an analysis of 4 publicly available cohort. So what they did, they kind of recruited 19,000 participants, like big number, and then they did uric acid, serum uric acid at the get-go, and then they followed them in the future. And what did they find? What's expected, that if your serum uric acid is low, less than 6 milligram per deciliter, your probability to have gout in the future is less than if your serum uric acid is more than 10 milligram per deciliter. So the survival of you survive like gout-free period goes down. Now what's interesting is that if you look at this highlighted box, so they picked people who had serum uric acid more than 10 milligram per deciliter, more than 15 years, so they have the duration, they have the level. Only 50% out of them, they do have gout, or they develop gout, which is interesting. You'd expect that more than this, they should actually have it. So this tells us that hyperuricemia is necessary, but it's not sufficient to cause gout. Now, the other important factor about the deposition is that crystals, you can find crystals in between attacks. So not always if you find crystals, it means that you are in a gout attack, in an active attack. This tells us that, well, maybe the crystals itself have a problem, like maybe they are coated with a specific protein causing this inflammation, or maybe the individual patient response. And this actually excites the idea of the dynamic inflammatory tone. It's unfortunately out of the scope, but it's like an exciting new knowledge on why crystals not always causing gout. And this also was replicated in the double contour sign by the ultrasound. So you find the deposits, 25% out of the asymptomatic hyperuricemia, they do have the deposits, but that they're not necessarily going to develop gout. And unfortunately, we don't really have an answer on who have a urate deposits are going to develop gout. The old trials of the all urate lowering therapy does suggest that if you're going to reduce the amount of serum uric acid, you're going to reduce or control gout. And then it seems to be that the number 6 or below, kind of the magic number, and it's a scientific fact. However, some people are trying to argue against it, but this is a scientific fact that we have. So managing gout is suboptimal. So 1/3 of the patients who are treated for gout are on appropriate doses of urate lowering therapy, which is really strange because it does seem to be a logical disease. It seems that we're having a target, like we always complain that, well, on rheumatoid arthritis or psoriatic arthritis, we don't have a target. Now we do have a target, we have a number. So how come we can't reach this? How come it's complicated? Some of the reasons that the diagnosis of the, treating uncontrolled gout is difficult is by diagnosis. You know, we still need synovial fluid. We still need to see crystals. You need to rule out infections. You need to rule out other crystal disease. Now, ultrasound and DICT scan are very interesting and accurate tests, but again, you cannot exclude the other possibilities. Please remember that serum urate is not sufficient, even if the number is high. And then they come up with clinical algorithm where you don't have to take the aspiration all the time. Patients coming at night, there are some small joints, they're refusing to take the synovial fluid, so they come up with different algorithms to do that. So for example, this is a patient, he's a male, hypertensive, he has high serum uric acid, and he presented with one day acute attack, cannot really walk on his feet. If you go through with different algorithms, now this is one of them, it's an example, you actually see that this patient scores about 11, which means that in 87%, based on this algorithm, this patient has gout. Well, maybe not. Actually, in this case, this patient had Staph aureus septic arthritis. So every time when you're dealing with something that doesn't respond well the way you're thinking, please revisit your diagnosis because it could be not. Another important cause for uncontrolled gout is based on the natural history of the disease. Now we understand that it starts kind of mild and then it goes through the way and becomes really advanced and severe and difficult to control. So you keep in your mind which area or which point in time we are treating the gouty patients. Now chronic kidney disease patients, either if they are on hemodialysis or they are going to the ward hemodialysis, they are going to be a challenging population, aren't they? It's a disease, it's a patient population problem. That's why we can't really control them. Now, we know that 20% of our gout patients, they do have chronic kidney disease. Please remember that allopurinol is not nephrotoxic. This is a discussion that you're going to have with nephrologists, at least some of you are going to have with your nephrologist. It's not a nephrotoxic drug. The thing is with allopurinol hypersensitivity that happens more in chronic kidney disease, it's kind of an allergic reaction rather than a toxic buildup, right? So we understand it has a high risk in patient who has chronic kidney disease, and then they suggested that there is a dose reduction. However, there is no science behind that. It's more of a theoretical background that we actually adopted. And there was no hard data. Where does this come from? And even if you go by the ACR and ULR, you can find that there is no consensus on how low we should start and how slow we should go up. But this is what we are going to do anyhow. Now, other possible explanations for why is it difficult to control gout. Maybe it's a suboptimal compliance. Now, it's always easy to blame the patient. Well, they're not compliant, and that's why we cannot really control the disease, right? Or is it the suboptimal dosing? Maybe we don't use enough dosing to reduce the serum urate. So you have actually to titrate it up. Most of the general practitioners, they kind of do it in the beginning and they don't follow it up. They continue the same dose. Or maybe it's the drug, it's not really effective. Now we do understand that allopurinol, there is a polymorphism that actually controls the delivery of allopurinol inside the cell. And maybe some people are going to respond less and some people are going to respond better. So it maybe could be all of these factors altogether. I just want to show you that we actually have an evidence that in this trial where it actually was run in the UK. So basically they have 517 patients uncontrolled gout. They put them in two groups, they randomize them in two groups. The first group is a treat to target. They are a nurse-led practitioner, so they are trained how to treat gout, and they're nurses. And the other group was physician, general practitioners. So they followed these patients for 2 years with an intention to treat analysis. Very interesting results for me. So if you go through and see and compare, so the one on the left are the nurse-led and the other one is the general practitioner, you can find that 95%, I repeat, 95% on the second year, the nurse-led group, they reached to a serum urate less than 6. However, if you go to the doctor's group, that was only 30%. The results actually replicate itself. The number of flares, 8%, more than 2 flares per 2 years, and 25% in the physician group. The mean dose of the allopurinol, you can find that it's 460 milligram in the nurse-led group, while it was only 230, TOFI existence. I think what we can get from this study is, obviously nursing are good, but if you have a target, it's an achievable and attainable, and we can reach it if you make yourself go through it. So I think this is an important thing, is that maybe we don't have to have a new medications. Maybe we need to know how to use our pre-existing medications. Just wanted to bring your attention to a concept in gout, which is the time concept. So it takes time to accumulate uric acid to deposit. So not everyone deposits the same. A very excellent example here is the tumor lysis syndrome. This day the patient has uric acid of a normal result. The second day they might have it over 16 or 18 milligram per deciliter. They don't have gout because it takes time for you to deposit these crystals in order in the future to have gout. As long as you're having time to dissolve, to form the crystal, also you have time to dissolve it. So you have to have some patience. And the most important thing is basically it takes time for gout flares to stop. So if you're starting treatment and the patient keep having attacks, please remember, it's not a failure of your treatment. It's the time concept. You have to give it some time in order for you to dissolve and control this thing. Okay, so a couple of words on febuxostat. So febuxostat in real clinical practice, we kind of consider it as second-line urate-lowering therapy. It's actually appropriately used if you fail or intolerable to allopurinol. It has a distinct chemical structure, so those patients who has allopurinol hypersensitivity, we can use them as cells. There are a couple of reported allergic reactions, but you can use it. It's more expensive than allopurinol. Allopurinol box costs you about 10 to 15 reals. The febuxostat, it's about 110 reals. The other problem with the febuxostat is the dosing, because we have the 40 milligram pill, maybe the 80, and that's it. So you can't really titrate it up. And the problem is that the 40 milligram febuxostat is actually equivalent to 300 milligram of allopurinol. So if you started from the beginning, you're going to plumb the serum urate level, and then that might induce an attack. All the big talk about the black box warning, about increasing cardiovascular risks, but the future actually, or the subsequent analysis did not really show big difference between febuxostat and allopurinol. And people are becoming more adaptive of the use of febuxostat and not really be really scared of this cardiovascular risk factor. Uricosuric therapy, it's an old medication that's been revived in a way. This study actually from 1959 did show it has some efficacy. What they are suggesting in the newer trial that you can use it as an add-on. So you add it on to the allopurinol to get the best results. It does have GI upset. It does have some rashes. The renal stone is not a big issue as we used to think, unless if the patient has nephrolithiasis from the get-go. Pegloticase. Okay, so pegloticase, as you remember, all the mammals, they do have the uricase, and then that's why they don't get gout, except us and few other mammals, including the Dalmatian dogs. We don't have uricase, and then that's why we get gout. So basically, it's a recombinant mammalian uricase. The pegloticase is a recombinant mammalian uricase that is attached to PEG. To polyethylene glycol. Now, the FDA statement is that we use it for treatment of chronic symptomatic gout that are not responding to maximum doses. They did not really specify what maximum of xanthine oxidase. This is the FDA label. Just a quick poll here. Any one of you have used in Saudi Arabia pegloticase? Those who does, just please raise your hands. And I guess the reason is it's not yet Saudi FDA approved, and it's actually $32,000 per vial. So this vial is actually costing $32,000. But I guess mainly because we don't have the Saudi FDA approval, yes. So the trial, it was, you have this expensive drug, we have this refractory disease, it should do this, right? So most of the patients who are in red, who take the pegloticase after the first dose, it's like a magic, they plumb down, and then we think that we finally solved the problem. Well, it's not completely correct, because it actually, up to 56% of people, they actually did not respond, or the uric acid started to raise up again. So that was a disappointment. So then obviously the studies goes through, and then we find that there is an immunogenicity with pegloticase, and then there was so many efforts trying to overcome this immunogenicity. So they started first with the high zone tolerance, which basically they increases the dose to oversaturate the antibodies, but that didn't work. So then they tried to use other immune mediators like the MMF, mycophenolate, like the azathioprine, leflunomide, in case reports with some successes, till they actually, and this was actually presented in the poster in ECR of 2018 of series of patients that they use methotrexate. So they bring this fact and then they put it in a randomized double-blinded trial where they actually, which is called the mirror trial. So what they've done here is that they bring the patient population death. These are the patients who had hyperuricemia, chronic gout, not responding to xanthine oxidase inhibitor, and they have the symptoms. So they were not really strict about what was the dosing that you have to use, but these are the patient population. They should have gout that's not controlled, or tophaceous gout. So what they did, they brought the patients at the pre-study period. They used methotrexate to test the tolerability, and then after they did that, they randomized the patients into two groups. One group, they used the methotrexate, and the other group, they used placebo instead of methotrexate. And this is the patient disposition. So you find the one on the purple are the one who used the methotrexate. About more than 70% they continue till the end of the study. While if you go to the other side, the ones on placebo, there was actually only about 30% or 40% that they completed the study. The main reason for discontinuation is drug inefficacy. That was the main reason. And this is the primary endpoint. They did meet it nicely. Patients who are taking methotrexate, they have significantly better response than those who did not take the methotrexate. And if you go through the adverse events arms, they actually did very well. You know, patients who took the methotrexate, they had less infusion reaction. The minor side effects were comparable between both groups, and it worked fantastically. It doesn't make sense to treat patients with gout with methotrexate in order to make the pegloticase work, but it did work without the major side effects. However, just to remind you, most of these patients, more than 70% of these patients, they develop acute gout flare. So, about time. Going back to take-home messages. Now, hyperuricemia, we show you that it's necessary, but they are not sufficient. There are some other factors that we don't fully understand yet. There are other factors about the crystals themselves, about the host, which is the synovial host, that we still need to know and understand. Remember that difficult to control gout does not mean by any means that it's a resistant disease. We need to know how to use our medications better and better to control the disease. Allopurinol continues to be the first line, and it's not nephrotoxic. Appropriate urate lowering therapy does remove the deposits over time. So you have to give it some time. It's not something that happens very quick. You have to give it some time. You have to educate your patient that it takes some time. And treatment to target is something that is achievable in gout. I'm done. Thank you.
So we'd like to thank all the speakers, and we open the floor for any questions. Yes?
So please, the microphone here, please.
We can. Mike, please. Can you raise your voice, Dr. Samar?
Thank you, everybody. It was really an amazing session this morning. My question is for Dr. Al-Harthi. I know that you did not touch with the erosive osteoarthritis. What is your experience with erosive hand osteoarthritis? How do you treat it? Do you give patient a trial of hydroxychloroquine, methotrexate, or you don't do anything? Thank you.
Thank Dr. Samar for this excellent question. Osteoarthritis, erosive osteoarthritis of the hand is still challenging. There was some talks in the past, hydroxychloroquine may work, methotrexate may work, also small dose steroids for short period may work, but the evidence is not that of great. I tried before hydroxychloroquine, in fact, in my patients, but I didn't find any really significant improvement, and the recent evidence is not really supporting use of these agents. Huh? Yes.
Okay. So I have a question for Dr. Attar. Dr. Attar, do we have any time for starting methotrexate and dose, for example, before for uricase therapy? Do we have any time, how many months or weeks before starting that? And any dose?
Oh yeah, now it's working. Okay, so the question is that what's the dose of methotrexate, when to use it before using the pegloticase? Based on the trial, they use it 4 weeks only. 4 weeks is enough before you start the pegloticase, and the dose was 15 milligram per week.
And should we continue after that to reduce or no?
So again, if you reach to, now this is an area that they haven't really decided yet. So if you reach to your serum urate target, then when are you going to stop? Are you going to continue? So most of them, they will give it, like the trial design was only for 6 months, and then you kind of go to whatever xanthine oxidase inhibitor you're giving before. So since the stop, at the time of the stop of pegloticase, you're going to stop your methotrexate. But yeah, so you'll use it while you're using the pegloticase. The duration of use is about 6 months based on the trial.
Thank you.
Thank you very much. My question is for Dr. Basma. 2 questions, actually. For premenopausal women with GIO, now with the bisphosphonate, considering the long offset of the medication, would you still, I know you mentioned it's a strong recommendation, would you still consider it as a first line, even with the childbearing concerns patient? Or would you go for denosumab?
Sorry, you said patients with the GI bleeding?
No, GIO, steroid-induced osteoporosis, premenopausal. What would be your first treatment? Bisphosphonate or denosumab?
Postmenopause.
No,
Yeah.
premenopausal.
Premenopause.
Yes.
Yeah, the problem, there was no time to, talk about a lot of things. But in childbearing age, you have to be very careful, of course. You can't use alendronate because we don't know about the long-term effect on the bone. It can stay for years. So even if you stop it like 6 months before pregnancy, still it can have some effect. So probably you will go for a short-acting medication. I would prefer denosumab here.
Okay.
Because all bisphosphonates are long-acting. This is, of course, not evidence-based.
Okay. The second question, sequential therapy. If you have to give a bone-forming and anti-resorptive sequentially, which one you start first?
No, always, even in primary osteoporosis, always start with bone-forming agent, and then, in general, after bone-forming agent, whether it's teriparatide or Romo, you can't stop treatment, no drug holiday. Okay, so you have to continue with anti-resorptive. You don't even you don't go from like teriparatide to Romo. You go from bone forming to anti-resorptive. This is standard in primary or secondary osteoporosis.
Thank you.
So, I have a question for Dr. Mohammed Al-Garni. Dr. Mohammed, regarding the side effect of the MSK side effect after using the immune checkpoint inhibitors. So what, as oncologist per se, what you will do in this situation? Should we hold the medication for a bit of time? Should we stop it at all or switch to the other medication?
Thank you, Dr. Fahd. So for grade 2 toxicity in general, we would continue therapy except for myositis. Sometimes as an oncologist we accept some sort of toxicity if we are aiming for high chance of cure for the patient. So we might accept some sort of toxicity at the expense of achieving cure, increasing the cure rate. So overall, grade 2, you still can continue immunotherapy. However, for myositis, it's better to hold immunotherapy. And again, it goes case-by-case discussion, and that's why we encourage the discussion between the rheumatologist and the treating oncologist all the time.
Okay, we'd like to thank all the speakers, and thank you so much.
شكرا جزيلا دكتورة سهام ودكتور فهيد على إدارة الجلسة. والآن الدكتور حنان تكرم المتحدثين. نأمل منكم البقاء على المنصة. البداية مع الدكتورة سهام الرشيدي. Thank you, Dr. Siham, for your moderating of the 9th session. And Dr. Mohammed Al-Garni. ودكتورة بسمة الوهابي. دكتور فايز الحارثي. فايز الحارثي وبعدين دكتور محمد. صورة جماعية لكل المتحدثين. السادة والسيدات، الآن استراحة قصيرة لمدة 10 دقائق ثم نعود لنستكمل جدول أعمال المؤتمر. طبعا احنا تجاوزنا وقت الاستراحة، فممكن نستعجل شوي حتى ما نأثر على باقي الجلسات. والسيدات، ندعوكم إلى القاعة لاستكمال جدول أعمال المؤتمر. ندعوكم إلى القاعة لبداية الجلسة التالية. Ladies and gentlemen, welcome back. Now let's move to Satellite Symposium sponsored by Pfizer with Dr. Ziad Al-Zahrani.
Bismillah ar-Rahman ar-Rahim. Good morning, everybody. It's a great pleasure for me to participate in this very interesting conference. And today I'm going actually to present a study that we did with our colleagues regarding the use of tofacitinib in rheumatoid arthritis. And here just a disclaimer for the company that they did not sponsor this trial and they have nothing to do with it. So the study is assessing actually the efficacy and safety of tofacitinib in rheumatoid arthritis, which is a retrospective study from 2 centers in Jeddah, Saudi Arabia. The idea came actually when we noticed that the oral surveillance study have shown some increased side effects, including cardiovascular disease and malignancy and other side effects. So we thought we would like to have a real practice scenarios from our own experience, and we had this kind of collaboration between us and the Armed Forces Hospital in Jeddah, and we did this study that is relatively small, but at least it gives us some ideas about what we expect to see from the real practice scenarios. We know that real practice scenarios is really good because it can enlighten us about the side effects as well as the efficacy. So I'd like first to thank our colleagues who have contributed, including our fellows, Dr. Hanan Al-Maliki and Dr. Noor Al-Jahani, who had played a great role, and also the contribution of Dr. Ahmed Al-Hazmi and the rest of the colleagues. So a quick introduction for the study. As you know, rheumatoid arthritis is a systemic autoimmune disease characterized by chronic inflammation and the destruction of the joint. It can lead to functional impairment and disability and reduced quality of life. And if you look into the 2019 EULAR recommendation, they do recommend the treat-to-target approach and intensive treatment using the disease-modifying anti-rheumatic drugs. And the use of the JAK inhibitors has been established now in the treatment of rheumatoid arthritis. Those patients who are moderately to highly severe or active rheumatoid arthritis who have failed or are intolerant to the conventional synthetic DMARDs. Now, the clinical trials have demonstrated that tofacitinib, whether monotherapy or in combination with conventional synthetic DMARDs, is able to considerably reduce the disease activity and also improve the health quality and function as well. So in 2012, as you know, the tofacitinib was approved by the FDA for adult patients with moderate to severe rheumatoid arthritis. And we have mentioned something about the oral surveillance study, which was mandated by the US FDA. And this study, as you know, reported higher incidence rates of MACE, major adverse cardiovascular events, and malignancy than tumor necrosis factor inhibitors. And the risk of opportunistic infections as well, like herpes zoster and tuberculosis, and some abnormalities in the liver function test were found in this study. So, as you know, still we are having the availability of these JAK inhibitors as a treatment options, and we thought we would like to see what will be the experience in our daily practice of this drug in our patients with rheumatoid arthritis. So the study objectives were, to aim is to assess the clinical efficacy, the safety, and tolerable response to the tofacitinib in rheumatoid patients encountered in routine clinical practice. And this is actually the first, probably to our knowledge, study that was done in Saudi Arabia. We have seen some studies now coming from the Gulf, like from Qatar yesterday, reporting about the same issue with JAK inhibitors, which gave us some idea that probably we are not expecting to have, a lot of side effects as has been reported from the oral surveillance. So this is a retrospective study that was conducted at the National Guard Hospital, Jeddah, and King Fahd Armed Forces Hospital. And it was starting from 2020 to 2022 when we started to collect the data. The participants were diagnosed with rheumatoid arthritis according to the classification criteria. And the inclusion criteria included all the patients who are 18 years and above and treated with tofacitinib between 2015 and 22, and evaluated at the initial visit, baseline, and every 6 months thereafter at least. So the exclusion criteria were, patient aged younger than 18 years or recent start of tofacitinib, less than 1 month. Looking into the methods, this is a patient's record were reviewed for the following information at the start of the treatment with tofacitinib. So we included actually demographic data, including the age, the gender, the comorbid illnesses, because they are really important. We have also focused on the cardiovascular risk associated, risks. So we included also the status of the rheumatoid factor and anti-CCB, and the presence of erosions and extra-articular manifestations and history of previous DMARDs and concomitant medications. We assessed the disease activity through the DAS-28, and actually the cutoff limits for remission and low disease activity. So the data that was collected for the safety included reasons for discontinuation, if any, and adverse events in the form of MACE, malignancy, serious infections requiring hospitalization, VTE, and herpes zoster were documented. Also, some lab measurements were reviewed, including the hemoglobin, platelets, leukocyte counts, lipid profile, and liver function tests. So if you look into the age of the patient, that was really the mean age of the patient was 48 years, which is kind of interesting because we are trying here to follow the recommendations from the guidelines. And in fact, this is different from what we have seen from the oral surveillance. The mean age for the patient in the oral surveillance was 60 years. And in fact, about 1/3 of the patients were more than 65. So this is a little bit different from what we have seen in the oral surveillance. Of course, the gender duration of the disease was around 10 years, and the females were the majority in this study, as always in rheumatoid arthritis. We're talking about 84% of the patients. And interestingly, looking into the obesity in the populations, we are talking about 48% of the patients were having a BMI more than or equal to 30%. Looking into the comorbidities, only 1/3 of the patients, like around 34%, did not have any comorbidities. However, 2/3 of the patients had comorbidities, including diabetes in about 1/3 of the patients. Hypertension is almost in 50% of the patients, and ischemic heart disease was only 4% of the patients. In fact, if you look into the oral surveillance, the patients who had ischemic heart disease were almost 11%. The rheumatoid factor, or CCB status, is seen in 86% of the patients here, and presence of erosions was only in 30%. We know that those patients were already on treatment, and including also some biologics before, who failed either conventional, synthetic DMARDs, or biologics. So probably that has helped in reducing the structural damage in this group of patients. Extra-articular, manifestations was seen in 14%, and those patients, almost 1/3 of the patient had severe disease, and 2/3 had moderate disease activity. So if you look into the treatment regimens those patients have used, as a monotherapy, when you talk about tofacitinib, is seen in 1/3 of the patients. However, 2/3 of the patients were using it in addition to the other conventional synthetic DMARDs. And you can see the different DMARDs used here. Probably the commonest among them is methotrexate in about 56% of the patients. Again, because those patients are having severe, moderately severe, or moderate disease at least, good percentage of those patients, around 50%, had steroid as well in addition. So the treatment regimens, if you look into here, those patients had already given a biologics in about 2/3 of the patients. 74% of the patients had received biologics, and at least 1 or 2 of the biologics that have failed in those patient populations. And the same thing for the DMARDs, the conventional synthetic DMARDs. If we look into the efficacy for the patients who have been treated with tofacitinib here, we are seeing about 50% achieved remission, which is really a good indication that the drug works well. And in about 30% of the patients, they had low disease activity. If you look into the other observational studies that have looked into similar things, we are having almost similar data to what has been reported in the literature. Now, the time to achieve the treatment target was between 12 and 26 weeks. Now let's look into the treatment discontinuation and the reasons for the discontinuation. The total duration of therapy was about 18 months. If you look into the median duration for the oral surveillance, it was like 4 years. So we are here having about 18 months, like a year and a half. The discontinuation was seen in about 30% of the patient, and the reasons included lack of efficacy in about 14% of the patients. Some of the patients got pregnant and it has to be stopped, and some adverse events in 10% of the patients. If you look into the adverse events here, which is important, that's what we were trying to focus on to see if we are going to have any bad signals in this data. So we've seen about 6% having dyslipidemia. Herpes zoster was reported in about 4% of the patients, and serious infections requiring hospitalizations in about 4% in the form of UTI or pneumonia. and only 2% had neutropenia. However, if we look into the VTE, MACE, or malignancy, fortunately, none of the studied patients developed serious adverse events among these outcomes, which is really quite reassuring, at least for the period of the time that we have studied them. The laboratory changes, for example, showed some patients had an element of increase in the lipids as expected. Leukopenia is only 2% of the patients, and neutropenia less than 1,500 in 2% of the patients. So none of the studied patients developed lymphopenia, an increase in the liver enzymes, or creatinine. So we looked into the predictors of achievement of the treatment target. Are there any predictors in this patient cohort that might help us predict they are going to respond to the treatment? We did not find any significant relationship between the different characteristics and including the demographics at baseline, the disease characteristics, or previous treatment regimens. So you can see we looked into the patient's demographics, the duration of the disease, the comorbidities, serology, presence of erosions, extraarticular manifestations, and it seems that there is no any associations or predictors of response. Again, in terms of the monotherapy, the drug was given as monotherapy or in combinations with conventional synthetic DMARDs, it seems that it works despite all situations. So regarding the discussion of this study, this retrospective real-world study analyzing the patient with rheumatoid arthritis treated with tofacitinib from 2 centers in Western Saudi Arabia, it showed a good response to the tofacitinib treatment even without concomitant use of methotrexate, and in patients who had multiple biologic DMARDs failure. The tofacitinib significantly reduced the disease activity, and we've seen that about 50% achieved remissions and 30% achieved low disease activity. So we are talking about 20% who did not respond. Looking into the adverse events leading to the discontinuation, we've seen that some patients, had, discontinuation due to inefficacy or due to the presence of some side effects or because of pregnancy. So in our study, the most common infectious, adverse events were herpes zoster, which is seen in 4% of the populations in this study. In fact, it's more or less similar to what has been reported in the literature, which is ranging between 3.7% to 4% or even more. So few patients developed an increase in the LDL cholesterol, which is one of the expected, features seen with these kind of treatments. However, neither hepatitis B reactivation nor tuberculosis was reported, and none of the enrolled had VTE, MACE, or malignancy. As usual, like in this study, there is limitations, and one of the limitations of our study is a small number of the participants, which reached about 50 patients, and the duration of the study is probably limited, about 18 months in total when we talk about the duration, mean duration, although some patients had it for longer, but really we need to have a longer study to capture probably some of the side effects like MACE. But at least for this time durations, we see no increased risk if you choose your patients rightly, like in this patient population who are younger, a relatively younger population than what has been reported in the oral surveillance. In fact, the patients in the oral surveillance with 50 years and older having, at least one risk factor for cardiovascular disease. So now we do not recommend to start this medication in patients who are more than 65 years of age or having ischemic heart disease to be able to reduce the possibility of developing side effects. So tofacitinib, in conclusions, is a valuable and well-tolerated treatment option for rheumatoid arthritis patients. And the tofacitinib induced high rates of low disease activity and remissions in moderate to highly active rheumatoid arthritis as monotherapy or in combination with conventional synthetic DMARDs, which reinforces that tofacitinib effectiveness in real clinical practice that has been established even from other studies. So with this, I thank you for listening and thank the audience for their attention.
إذا شكرا دكتور زياد الزهراني. جاهزين البرزنتيشن اللي بعده؟ الياس.
ندعو الدكتور مفضل الصعود إلى المنصة لتقديم العرض القادم.
السادة والسيدات، مباشرة إلى المحاضرة التالية برعاية شركة ليلي مع الدكتور مفضل العيثان.
السلام عليكم. بسم الله الرحمن الرحيم. Thank you all for attending our satellite symposium. My name is Mufaddal Al-Aithan and I am the Senior Immunology Medical Director for Eli Lilly. And I only have one disclosure to tell you, is that I work at Lilly, so obviously. So we're going to go over the baricitinib data. And I want to go over it in a little bit untraditional way. So the data really go in the clinical trials that involve over 3,700 patients in multiple countries around the world. And that's very nice to understand the efficacy of baricitinib in patients, in a standardized patient with RA. And as you can see, we do have efficacy data, whether the treatment or the patient was treatment naive or CSD mild inadequate responder or biologic failure patient that even included multiple biologic failures. So that's very nice, but that is not enough to know about the medication and the practice in the clinic. So we do have real-world evidence data that really gives us the effectiveness of the medication in the real world. So does it match the RCT efficacy, or is it under or over the efficacy reported in the RCTs? And we do have about 250,000 patients around the world with these data. So we do have multiple registries that inform us onto the safety and efficacy of baricitinib. And interestingly, Saudi Arabia is involved into one of these studies or registry studies. So we do have about 25 registries that involve more than 6,700 patients, and it does inform us about the efficacy as well as the safety for patients and the dosage and the treatment preferences. So when we look at the red graphs, we do see results from the RCT data, and we do see the efficacy from an RCT perspective, and the orange graphs are the real-world data. So we see the effectiveness of real-world data in baricitinib supersedes those reported from the RCTs, and we do have 7 to 8 out of each 10 patients entering remission or low disease activity in the real world on baricitinib therapy at 6 months. So if we go over one of the cohorts or registries, which is an Italian data about patients on baricitinib, we see reduction of their DAS28 scores from baseline to up to 6 months, as well as CDAI and SDAI. And it's a very good thing that we look at CDAI always, so we don't have any lab interference with our assessment. So whether the patients were biologic naive or inadequate responders, we do see a significant response from baseline to 12 months in this Italian prospective study, and we do see remission rates that are very good as described otherwise. So this is very good, but the short-term data are not sufficient for a chronic disease. So the next question is, what's the trajectory if we keep patients on therapy for years and years in time. So we want to discover the maintenance of efficacy. We want to discover that monotherapy is available as an option. And we want to know that dose titration up and down, does it work or not for the patients that would like to reduce the dose after they've achieved remission, and treatment interruptions, whether they flare the disease or not. So this is from patients who were basically DMARD inadequate responders that started baricitinib therapy. And we do see that once they enter into remission or low disease activity at 6 months, not only they maintain it, but they have a positive trajectory in time, and this goes up to 7 years. So that's a very positive treatment response curve over time. And we do see that even if we look at the DAS28 ESR and CRP, and we do see that 5 to 6 out of each 10 patients, or 6 out of each 10 patients will enter into remission and keep it for 7 years at least if they were CSD-MARD inadequate responders, and along with that is the improvement in the functional status. So what about patients that were biologic inadequate responders? And this included patients who even failed 2 or 3 biologics and more. So we do see again a positive trajectory once they enter into low disease activity or remission. At 6 months, they do maintain it for almost 7 years, and we do see that in DAS28 that 5 out of each 10 patients of these treatment-resistant patients otherwise entering into remission and keeping it for almost 7 years. And along with that is the functional HAQ-DI, or the functional status, which is very important. So the same figures give or take are reported from registries in Germany, UK, and Spain, and that is consistent with up to 7 out of each 10 patients entering remission or low disease activity. So we're not seeing that there is an efficacy effectiveness gap, but it's actually the effectiveness in the real world is likely to be higher than what was reported in the RCT program. So the next question is, the EULAR recommends, and this is, I think, last year they recommended to taper and stop steroids, and also taper biologics or TSD-MADs once a patient is in remission. And the only JAK inhibitor that has 2 approved doses is baricitinib. So you can titrate up and down according to the patient's response and needs. So if you titrate down, are you going to maintain remission? Where the data from our studies suggest that up to 80% of the patients are likely to maintain their response if you do titrate down to 2 milligrams from the 4 milligrams. So that's about the efficacy. Now next is the spicy topic, and I like spicy things. So the spicy topic about JAK inhibitors is basically the safety. So the safety of a JAK inhibitor is a very interesting or a hot topic nowadays, and we see that patients who were on baricitinib that were followed for more than 9 years and have a safety reported in this all-bari-RA study. And interestingly, that more than 62% were above the age of 50, and more than half the patients had at least 1 or more cardiovascular risk factors. And we see a split of 80-20 almost in their baricitinib dosing between 4 and 2 milligrams. So in this group of patients, we see that malignancy happened in less than 1 incident per 100 patient years, and MACE and VTEs happened around 0.5 incidents per 100 patients years. And we know that these outcomes are time dependent, so it makes full sense to express them in 100 patient years sort of results. So what's the safety from the real-world evidence? Does it match? Is it better? Is it worse than what was reported from RCTs? And again, I remind you of the baricitinib real-world evidence program. And we see that cohorts with large number of patients do report less than 1 incident per 100 patient years of VTEs. And I want to zoom into the Japanese trial, because Japanese trial contains or involved more than 4,700 patients. So that's a very good size or sample size for patients with RA. And not only that, but as you know, Japan has got a population that is aging, and we see that 55% of the patients are above 65 years of age, and 20% of them were even above 75 years of age. And we see that disease duration was in the 11 years range, and we see that there were like 70% or so that were biologic inadequate responders, and around 19% were even other JAKs inadequate responders. So they were not the simplest RA, to say the least. So in this group of patients, we see that the MACE events happened at less than 0.5 incidents per 100 patient years, and the malignancy rates were less than 1 incident per 100 patient years, which is not only consistent with what we know, but it's also lying within the known values or expected for patients or known cohorts for RA. So that is within the expected range of cohorts with RA. So how likely the drug is to survive is a very important question, because when you treat a chronic disease, you don't only treat today and tomorrow, but you treat for a very long time. And we see that from a Swedish registry that baricitinib had better survival when we compare it to other JAKs as well as other biologics, with the only exception that is being rituximab. So now, one of the trendy topics nowadays is how much am I going to spend to treat a patient, or the cost efficacy. Now, when we think intuitively about cost efficacy, we tend to think that a cheaper medication is a more cost-effective medication, but that really undermines the second part of the equation, which is efficacy. So you have efficacy on one hand, cost on the other hand, and the real question is how much am I going to spend to achieve a response, not how much am I going to spend per medication. So if we look at the patients with RA, and if you only look at prescriptions, patients who achieve remission cost more at first, second, and third year, but that's a very tunnel vision of looking at things. Because when you zoom out, you look at the overall healthcare bill, if you don't achieve remission, you're going to spend more on patients, and that includes joint replacements, cardiovascular treatments, IV infusions, hospital visits, so many things that you don't capture when you only look at the treatment of RA. So to save on the healthcare bill, you need to get remission. So the next thing I'm going to talk about is pain, and pain is very important for the patients. In fact, it is one of the psychological distressors, one of the things that impair the physical function and decrease the quality of life for patients with RA. And interestingly, here physicians and patients do differ quite a lot. Physicians tend to look at swollen joints for activity, whereas patients tend to look at pain for activity, and that's a very interesting split, because in the real world, even patients that achieve remission do have some remnant noticeable pain, and that is not something that we can easily dismiss. So the question is, do we have a treatment that has an impact on pain? And this data comes from our BEAM study, or RA BEAM study, and we see that baricitinib achieved higher pain control compared to adalimumab. And not only was this achievable at 4 weeks, but the more time you spend, the more likely you're to gain significantly. And it did achieve that quickly, even on the higher end pain measures, or at 50–70% reduction of pain was achieved better and faster by baricitinib compared to adalimumab. Next is, if we fail everything, are we still going to have a pain reduction? And interestingly, that baricitinib, whether it controls or does not control inflammation, it does reduce the pain consistently. So that leads us to the conclusion that there is a direct effect on pain for baricitinib, and this direct effect on pain is rather quite a big one compared to the other biologics. So next I'm going to introduce the concept that we spoke about earlier, and I would like to give you an example, is that if you buy a medication for a single dollar for 10 patients, then you spend $10, but if you get the response in one, then you spend $10 to get one response. And if you buy it for $2, 10 patients, you get response in 5. You paid $20, but you paid 4 per responder. So it's not only the direct cost, is how much you pay per responder. And this shows that JAK inhibitors were actually cost effective when you compare it to TNF inhibitors in achieving a response. So you're likely to reduce the cost on a larger scale if you endorse JAK inhibitors. So safety again, and we see that integrated safety from all the indications for baricitinib, and we see the longest and the largest experience with RA being the first indication. And we see that if you see the patients painted in red, these are the patients with events compared to all the overall pictures, the patients without events. Now you're likely to see that when put in context, this is a very small risk of MACE, and this is a very small risk of VTEs and malignancy and non-melanoma skin cancer. And the good question that comes every once in a while is that when patients or physicians ask, if I treat patients for longer, am I more likely to see adverse events, or are they more cumulative with time? And the question or the answer comes from our All-Bari RA program. And if you compare the incidence at 5 years, 6, 7, and 8, and then 9 years, you see that a stable, low rate of incidence of adverse events happening over time. And this is true for infections, malignancies, MACE, and VTEs. In other words, they remain stable over time. So that was my time. This is the product label for Olumiant. Thank you very much.
دكتور مفضل العيثان، شكرا جزيلا لك. اخواني اخواتي، مباشرة الى الجلسة التالية وهي العاشرة من مؤتمرنا السنوي التاسع للجمعية السعودية لأمراض الروماتيزم. يرأس هذه الجلسة الدكتور عبد الرحمن الراشد ودكتورة سعدية عبد الكريم. دعوهم جميعا الى المنصة لبداية الجلسة.
Bismillah ar-Rahman ar-Rahim. Assalamu alaikum wa rahmatullahi wa barakatuh. Good morning, everyone. Today, I would like to thank the organization committee for the excellent preparation for this course. Today, we will have the vasculitis session. It will be a fruitful session. We do have 4 speakers. Vasculitis, as you know, is one of the most challenging and interesting parts of rheumatology. We'll start by first session by Dr. Abdullah Al-Mutlaq. Dr. Abdullah is a consultant rheumatologist in King Faisal Specialist Hospital in Riyadh. He has a special interest and experience in vasculitis. His talk will be about the current management and guideline in ANCA vasculitis. Without any further delay, Dr. Abdullah, the podium is yours. Yes.
Just need some help with the clicker, please. First of all, Assalamu alaikum. We just need some help with the clicker, please, if you don't mind. Assalamu alaikum wa rahmatullahi wa barakatuh. Good morning, everyone. We'd like to thank the Society and the organizing committee for this invitation today. Also, would like to thank all of the attendees who came here, even if it is the last day of the conference, to listen to what I have to say, hopefully to live up to the expectations. The topic today will be about the guidelines and management of ANCA-associated vasculitis and what is new in the field. Of course, it's a field that we used to have more questions than answers. Thankfully, recently, we are receiving more and more answers of these questions, and I've chosen 3 of these questions to be discussed today in our talk. There are a lot of material that are not covered in general because it's a huge topic. I'll be happy to be here during the Q&A session and also afterwards to answer any questions that we have not spoke about. So this is the outline. So we'll start with an overview and general principles. The 3 questions, the first one will be how much steroids is really needed in induction and also in maintenance, and are there any alternatives? The second question would be what is the role of rituximab? And the third, what is the role of plasma exchange? And then we'll finish up with a summary of what we have spoken about. So this is the flag of vasculitis, still stratified, large, medium, and small, immune complex and none, and we'll be focusing on this box here in microscopic polyangiitis and granulomatosis with polyangiitis. In general, while addressing or reading any paper that is published, we need to keep in mind it is very difficult to get a homogeneous cohort, so it is very heterogeneous in getting the patients in any study that we read due to the rarity of the disease and also due to the many ways that the patients with GPA presents. Second, it is still believed that PR3 positive ANCA-associated vasculitis are more relapses and they have more severe disease, but luckily they respond better to treatment. Third, that patients, whenever we encounter a patient with GPA with a new symptom, always keep in mind the question, is it something that is chronic and we need to accept as a new baseline or something new indicating a new relapse? For example, the stable proteinuria and the peripheral neuropathy we always have with patients with small vessel vasculitis. A very important category of patients we need to recognize while encountering patients with vasculitis are these patients presenting with severe life-threatening diseases, either CNS, lung, or any system. Continuing on the principles of managing patients, usually the induction phase is up to 6 months and the maintenance phase is up to 2 years. But again, is 2 years enough or not? Multiple studies have came out with suggestions and hinting how much do we need. One of them was published in 2017 when they took 117 patients who were induced with cyclophosphamide and then maintained with azathioprine and prednisone. On the 2-year mark, they were stratified either to continue or to stop the maintenance treatment. Of course, when they continued for another 2 years, up to 4 years of maintenance, it resulted in less relapses. So again, is 2 years enough? Is 4 years enough? Or maybe we need to go beyond 4 years and continue. So now going to our first question, how much steroid is needed and are there any alternatives in the market? So what we are used to is to give for severe life-threatening disease 1 milligram for 3 days, followed by 1 gram IV for 3 days, followed by 1 milligram per kg per day, aiming to taper 0.5 at the 3rd month. A lot of studies had addressed this question. The most recent was the Pexivast trial, the very well-known Pexivast trial, which was published in 2020, where they addressed the need of prednisone and plasma exchange in severe life-threatening disease. We'll come to the plasma exchange part when we talk about it, but regarding the prednisone, they compared the standard, which we mentioned on the left upper corner, and they compared it with another protocol, which is a reduced dose. And they found that it was non-inferior. So the reduced dose was quite non-inferior to what we are used to giving the patients in terms of the primary outcome, which were death and end-stage kidney disease. A Japanese group published in 2021 their findings when they took 140 patients with patients with having non-severe GN or alveolar hemorrhage, and they stratified them and randomized them to either low dose steroids, which is 0.5 milligram per kg, aiming for 0 at 6 months, or 1 milligram per kg, aiming at 10 milligram per day at 6 months. So the primary endpoint was the number of relapses and BVAS, and the reduced dose was non-inferior, again, to the standard what we're used to. So two studies with good number of patients suggested that we don't need that much of steroids that we're used to give. Currently, the TAPER study, which is highly anticipated to publish their study results at the end of the year, where patients who are in remission, they were randomized either to stop at 6 months or continue for another 6 months, so the finding would be very interesting. Another study with the same concept, either to continue after inducing remission or continue prednisone or stop, and this is expected to publish their finding next year in 2024. As for non-severe disease, it can be used alone as a first line, but more than half of the patients will require additional DMARD. So it is advised to start methotrexate or Imuran at the start, just to reduce the toxicity of prednisone in treating these patients. So other alternative, the new kid in the block is avacopan. Avacopan is a C5a receptor inhibitor, and the classic trial in 2020 was aiming to show that there is no safety signals in treating patients with avacopan. But prior to that, the first study, the CLEAR study in 2017, which was the first randomized controlled trial to see if the patients will benefit from avacopan and alternating with the prednisone. And avacopan was shown to replace prednisone without compromising efficacy. The most recent and the most significant is the ADVOCATE trial in 2021, where avacopan was shown to be non-inferior, but not superior at week 26, but it was superior at week 25 and in week 52 in maintaining remission, and with a signal of benefit on patients with kidney disease, and of course infections was much less with people taking prednisone. Moving to the second question, what is the role of rituximab? Rituximab is still believed and it recommended recommended over cyclophosphamide in remission induction. And this belief started in 2020 with the RAVE and rituximab trial, when it was compared to the standard of care back then, which is cyclophosphamide, and it was non-inferior to cyclophosphamide, of course, with less toxicity that comes with cyclophosphamide in terms of neutropenia, bladder injury, and malignancy. Currently, the Endurance trial is trying a new approach, low-dose cyclophosphamide with rituximab in induction, aiming to reduce the toxicity of both rituximab and cyclophosphamide. The Meritsen trial, which was published in 2014, showed that rituximab was much more beneficial in keeping the patient in flare-free remission, and the rate of relapses was 5% in the rituximab group compared to 28% in the azathioprine group. And they published their finding also at month 60, and it showed the same results. Meritsen 2 compared tailored to fixed rituximab in terms of maintenance, and there was absolutely no difference. Meritsen 3 randomized the patient in Meritsen 2 after 28 months to either continue rituximab for another 4 doses 6 months apart, which comes to 2 years, or stop them. Of course, if you continue rituximab, you'll definitely achieve lower relapse rate. Similar to the first Meritsen trial, the Rituximab trial included 188 patients who were induced with rituximab, and then they were randomized to either receive rituximab 1 gram Q4 month or azathioprine 2 milligram per kg. And similar to the Meritsen, rituximab was superior to azathioprine. This was published and the ACR 19 as an abstract, still awaiting the final report of the trial. But what is the price that we pay for giving such much rituximab? So a study included 142 patients in the rheumatology, including lupus and ANCA-associated vasculitis, but more then 100 patients of them were ANCA-associated vasculitis, so that there's significant hypogammaglobulinemia and secondary immune deficiency. And the risk factor to have this is prior immune suppression to rituximab and prolonged glucocorticoid and female gender. Of course, giving IVIG randomly, just according to the level, did not show any benefits, but when it was given to patients with severe infections, the rate of recovery from the infection was much higher. Going to our final and third question, what is the role of plasma exchange? So we go back to the PEXIVAS trial. So patients who received plasma exchange showed that did not reduce the incidence of primary endpoint, either end-stage kidney disease or death, nor the secondary endpoint, which is sustained remission and serious infections. So there was a recommendation against using plasma exchange. And this was published in 2020. But going back in time to 2007, the MEPEX trial suggested that we should use 7 plasma exchange in addition to the standard of care, but they can only prove its benefit up to 12 months follow-up, and the four-year follow-up was really, they could not prove that it was beneficial, and it was unclear. So we see the contrast between MEPEX and PEXIVAS trial. There are a lot of factors that might lead to this. So in this 13 years gap, there was an improvement in diagnostic, and rituximab plays a major role, and also the supportive care. And that's why we see that the added value back in 2007 was more than when it was published in the PEXIVAS trial in 2020. So in general, plasma exchange is recommended for patients with higher risk of progression to end-stage kidney disease, recommended for anti-GPM disease, and not recommended for patients with pulmonary hemorrhage. So worth mentioning, again, a lot of trials and new medication trying to be introduced into the guidelines. So belimumab, first it was studied in the PREVAS study, and it was added to azathioprine and prednisone, but it did not reduce the risk of relapse. Currently, the COMBIVAS trial, which is recruiting mainly in France and Europe, trying to add belimumab to the standard of care of rituximab in maintenance to see does it continue to have a relapse-free maintenance. Abatacept is currently being studied as an added treatment to methotrexate, azathioprine, or mycophenolate, try to achieve sustained prednisone-free remission. A new CD20, which is used in hematological malignancies, was used in a case series in Cleveland with patients with severe relapsing disease and patients who have severe reaction to rituximab, and it showed very beneficial response. But of course, this is just a case series of 3 patients, and we expect down the road, probably in 5 to 10 years, for this to be studied in ANCA-associated vasculitis. So in summary, some insights that less is more. Can we say that about prednisone, cyclophosphamide, plasma exchange, and IVIG? More is better in terms of maintenance. So all studies showed that more is better in terms of maintenance, but the question still remains, rituximab 500 versus 1 gram, and the interval, is it 4 months or 6 months? Methotrexate and azathioprine, how much do we need it for how long? So as I mentioned at the beginning of the talk, a lot of questions waiting for some answers. We're getting answers year by year, hopefully to build a clearer picture. This is my last slide. So stratifying patients with severe or non-severe disease. For severe disease, GPA or MPA induction, still rituximab and prednisone are the mainstay of treatment, followed by cyclophosphamide. Plasma exchange and IVIG might be used. As for maintenance, rituximab is taking a bigger role in addition to prednisone. Azathioprine, methotrexate as maintenance as well can still be mentioned and used, and to a lesser extent, leflunomide and mycophenolate. As for non-severe disease, methotrexate and prednisone in induction, azathioprine also can be used, leflunomide and mycophenolate to a lesser extent. For non-severe disease maintenance, methotrexate and azathioprine, to a lesser extent steroids, and we try to keep them off steroids after 6 months, and also leflunomide and mycophenolate can be used in a very small segment of patients. By that, I conclude. I would like to thank you everyone for listening and attending.
Thank you, Dr. Abdullah, for giving us extra 5 minutes. So first of all, Assalamu alaikum wa rahmatullah. I would like to welcome you all. And first of all, I would like to thank the organizing committee, Dr. Hanan, for inviting me. I'm so happy even to co-chair this session with my older friend, Dr. Abdurrahman. And even the topic is of my interest, vasculitis. So let's welcome our second speaker, our lady rheumatologist. I remember you, Safi, when you were resident. So Dr. Safi Al-Qatari, she's a consultant rheumatologist working in Imam Abdurrahman bin Faisal University. She's going to talk about vasculitis mimickers.
Good morning, everyone. Thank you for inviting me to present in this meeting. I really appreciate that. So my talk today is going to be about primary vasculitis mimickers. It's a very wide topic, and I try to make it as short and as fruitful as possible. Okay. So I'd be talking about some conditions that can be misdiagnosed as primary systemic vasculitis and identify the differences of those mimickers in comparison to primary vasculitis, in addition to the overall approach to management. Vasculodides are defined by histological inflammation of blood vessels in various tissues, and it's characterized by the presence of inflammatory leukocytes in the vessel walls with reactive damage to the mural structures. This will result in either aneurysm and bleeding or stenosis and ischemia. And you're all familiar with this diagram, so it can be classified into small, medium, and large vessel vasculitis. And while prompt diagnosis of vasculitis is important, recognition of vasculitis mimics is equally essential. And distinguishing vascular inflammation from non-vasculitic disorders has significant therapeutic implications. And distinguishing primary from secondary vasculitis is very important, basically because the treatment will be even different. We should consider a mimicker when a condition shares clinical, laboratory, radiographic, and pathological features of vasculitis that may include purpura, end organ damage, vascular aneurysm or stenosis, and multi-organ failure. And it may take a whole day or more to talk about the vasculitis mimickers, but just to simplify things, we can classify it into its etiology, infection-related, malignancy, autoimmune, and others, including genetics and medications, and I'm going to talk about the highlighted ones briefly today. So the first case is about a 48-year-old man who presented with arthralgia, myalgia, and tiredness. He also had a red, painful eye. He went to the ophthalmologist, and the ophthalmologist diagnosed him with episcleritis. He had high inflammatory markers in addition to significant proteinuria. He denied any infective symptoms, weight loss, or skin rash. And his background was significant for aortic regurgitation detected 2 years ago and was awaiting an elective aortic valve replacement. Examination was remarkable for aortic regurg murmur, otherwise unremarkable. Investigations were remarkable for normocytic normochromic anemia, high ESR and CRP. Multiple blood cultures were negative, as well as HIV test, and urine dipstick showed +3 RBCs and protein with proteinuria of more than 1 gram. His P&K was positive with negative MPO and PR3, and ANA was negative. Echo showed no vegetations, and PET-CT showed no aortitis or collection. And to complete the workup, they ordered syphilis workup, and it was positive, indicating active syphilitic infection. The patient was then sent to the genitourinary clinic where they confirmed tertiary syphilis, and the patient was eventually started on penicillin and his symptoms improved. He underwent the cardiac surgery with fruitful outcome. So my first vasculitis mimic will be syphilis. So as we know, sexually transmitted infections are increasing worldwide, and syphilis is included. And of course, we are part of the world, and that's why we should put syphilis in the back of our mind when we see our patients. So tertiary syphilis could mimic large vessel vasculitis, and a subtype of tertiary syphilis is cardiovascular syphilis, which can mimic Takayasu arthritis and giant cell arthritis. It can lead to inflammation of the aorta and its main branches that will cause thickening of the aorta, aneurysm formation, and aortic valve incompetence. Around 11% of patients with untreated syphilis will eventually develop cardiovascular syphilis. And it's worthy to mention that the aneurysm will mainly affect the ascending aorta, and most of those patients will be symptomatic, whereas less patients will have the involvement of the descending aorta, and it's most likely asymptomatic. The other subcategory of tertiary syphilis is neurosyphilis, which could mimic giant cell arthritis. The presentation of monocular visual changes with relevant associated symptoms can be concerning for GCA. Which can lead to permanent visual loss if it was left untreated. And it's confusing because in both conditions, they present similarly with high inflammatory markers in both. And because the diagnostic yield of temporal artery biopsy is low, the patients can remain on treatment despite negative biopsy results. And a diagnosis of ocular syphilis in such cases can be missed, resulting in permanent visual impairment. In histopathology, it's characterized by lymphocytes and plasma cells infiltration in the perivascular spaces around the vasovasorum of the root of the aorta. It also, a characteristic of that, it has a lack of skipped lesions, which is present more with GCA and Takayasu, and there will be plasma cell microabscesses. Also, an entity that could mimic median vessel vasculitis is secondary syphilis, in which it can lead to secondary nodular vasculitis and erythema induratum. Rarely, it could mimic large vessel vasculitis with some reported cases in the literature. Syphilis also can rarely confound the diagnosis of a small vessel vasculitic process affecting the lungs, resulting in a mass lesion that can be misdiagnosed as a multisystemic disease other than syphilis. The sensitivity of the BDRL and the FTA antibodies are 73% and 96% respectively, and that's the way we diagnose patients with syphilis mainly. The coexistence of neurosyphilis with other manifestations in addition to the cardiovascular syphilis would give us a hint to the diagnosis. Moving to the second infection, mycobacterial tuberculosis. So we are endemic in TB. And because we have a lot of cases of TB, a lot of atypical presentation could be encountered. So it could mimic large vessel vasculitis because it could lead to granulomatous arteritis leading to a vessel wall thickening, aneurysm formation, and stenosis that can affect the aorta and its branches. The involvement of the descending aorta and renal artery may resemble Takayasu arthritis, and that's how we get confused. That could lead to peripheral gangrene. It could also mimic median vessel vasculitis, where it can lead to secondary nodular vasculitis, which is a type 3 and 4 hypersensitivity reaction. There will be nodules that will evolve into ulcerations, and that will lead to depressed scars and hyperpigmentation. In histopathology, there will be diffuse lobular paniculitis with granulomas, of course, and primary neutrophilic vasculitis in the small and medium-sized arteries and veins. It also can cause secondary cutaneous polyarthritis nodosa with lymphadenopathy, as in this picture. It also can confound the diagnosis of a primary small vessel vasculitis, so it could lead to secondary leukocytoclastic vasculitis and IgA vasculitis, and of course it could confuse us with Behçet's. Tuberculous aortitis may be differentiated from Takayasu owing to its tendency to cause erosions of the vessel wall with the formation of a true or false aneurysms. And it particularly affects the descending aorta in contrast with arterial stenosis that is more typical of Takayasu. And the diagnosis may be suggested by the coexistence of extrapulmonary tuberculosis and, of course, by tissue biopsy if it was feasible. The third and last infection is infective endocarditis. And endocarditis, as we all know, is a classic example of a vasculitis mimic. presenting in a similar fashion with multisystemic involvement and posing a significant diagnostic challenge. Infective endocarditis can cause mycotic aneurysm of the aorta and its branches, in addition to the pulmonary arteries, as well as small vessel inflammation in various organs, either from direct infection because of septic vasculitis or immune complex mediated deposition, which could lead to purpura and glomerulonephritis, or by an embolic mechanism. Findings such as splinter hemorrhages, low platelets, and ANCA may also be seen in both infective endocarditis and primary vasculitis, which could confuse us in relation to the diagnosis and management. The diagnosis with high clinical suspicion, we should order transesophageal echo and blood cultures, as we all know. And in one series of patients who underwent repair of the aortic aneurysm, around 2.3% of those patients had mycotic aneurysm. It could affect any arterial location. However, the most frequently affected area is the femoral artery and the abdominal aorta, followed by the thoracoabdominal and the thoracic aorta. And another interesting retrospective study that studied the clinical implication of ANCA in patients with infective endocarditis, around 18% of the studied population had positive ANCA, and it's chiefly C ANCA. And those patients characteristically had longer disease duration, more frequent purpura, and more kidney involvement, including acute kidney injury and rapidly progressive glomerulonephritis. And around 18% of those ANCA-positive patients were misdiagnosed as having ANCA-associated vasculitis. And because glomerulonephritis is observed in the setting of infective endocarditis, it's worthy to mention the histopathology when we biopsy it. So typically there will be a granular immune complex deposition on the subepithelial and subendothelial glomerular basement membrane, in contrast to the ANCA-associated vasculitis with few or absent immune deposits, or what we call post-immune glomerulonephritis. My second case is about a 53-year-old man who presented with dyspnea. He had a history of type 2 diabetes and coronary artery disease that was diagnosed 6 years ago. Echo showed global hypokinesia, mitral and tricuspid regurg, dilatation of the left atrium and ventricle with low ejection fraction. Coronary angio showed severe 5-vessel disease, and bypass surgery was performed. A month later, the patient presented with severe pain on the feet, followed by skin abnormalities. Examination showed ecchymotic nodules with central necrosis, in addition to livido reticularis and acrocyanosis. Doppler showed patent arteries. However, there was an erythematous lesion, and labs were remarkable for a white blood cells of 8.5 and 3% of eosinophils. CRP was only a little bit elevated, and creatinine was marginally high of 1.7. Urine protein was 800 with positive 3 white blood cells, positive 2 RBCs, and no granular casts. Viral hepatitis was negative, as well as autoantibodies and complements. So what do you think? Okay. So deep cutaneous biopsy showed bully in the dermis and epidermis with fibrinoid necrotizing inflammation of the small arteries and perivascular infiltration with lymphocytes and eosinophils. And the report of the pathologist indicated probable vasculitis, most likely polyarteritis nodosa. However, he wasn't able to exclude cholesterol embolization. And based on that, the patient was started on prednisolone 1 milligram per kg a day. And after a week, most of his skin lesions improved. However, the necrosis of the 4th digit of the right foot got worse, and amputation was carried out. In histopathology, it was the same as the deep cutaneous biopsy, but in addition to that, there was cholesterol crystal cliffs in the lumen of the small diameter arteries of the skin. So the patient's diagnosis was necrotizing vasculitis due to cholesterol embolization. The patient was eventually started on cyclophosphamide, simvastatin, and prednisolone 1 milligram per kg per day for 4 weeks with a tapering plan. And after 4 weeks, the creatinine returned to baseline and the skin lesions improved. So cholesterol embolization occurs when erythematous plaques rupture and release plaque material into the vessel lumen. The known risk factors include old age, peripheral vascular disease, and severe atherosclerosis of the ascending aorta. Around 1/3 of patients with cholesterol embolization will either have vascular surgery, angiography, or angioplasty hours to weeks prior to presentation, or anticoagulation and thrombolysis hours to days prior to presentation. It most commonly affects the extremities where it manifests with symptoms of limb ischemia in addition to kidney involvement in some patients. And in most cases, vasculitic lesions are found in the lower extremities. Hands are usually unaffected. Laboratory findings typical for vasculitis in the setting of cholesterol embolization includes elevated inflammatory markers, thrombocytopenia, eosinophilia, and transient hypocomplementemia. So it's very confusing sometimes. And it's very critical to have an ophthalmologist checkup because we should never forget a retinal disease, which may help us in diagnosing those patients. As you can see here in the arrow, there are cholesterol embolization in the retinal arteries. The diagnosis requires histological confirmation with a deep skin biopsy showing crystals in the cutaneous microvessels. And the skin biopsy can be diagnostic in up to 92% of patients. The treatment is largely supportive. However, few case reports showed benefit of steroid, simvastatin, and elioprost, but still no widely proven specific therapy. And in some reports, they described improvement on steroids with kidney involvement. And in very few case reports, there was an improvement on steroid and cyclophosphamide, especially if an inflammatory reaction occurred at the site of embolization in distal arteries, mimicking vasculitis, as in our case here. The third case is about a 50-year-old man with a background history of resistant hypertension and history of Langerhans histiocytosis. He was referred to rheumatology with probable inflammatory arteritis. That was followed by detection of bilateral renal artery stenosis during the investigation for severe hypertension refractory to medical therapy. CT angio of the abdomen showed diffuse wall thickening of the abdominal aorta in keeping with aortitis. However, no serological or clinical evidence suggestive of vasculitis was present. Medical history included cranial diabetes insipidus, subclavian artery stenosis, spinal stenosis requiring surgery, and generalized bone pain. So putting things together, cranial diabetes insipidus, bony pain, and Langerhans cell histiocytosis, what are you going to think of, guys? So it would be mainly Erdem-Chester disease or histiocytosis, Langerhans cell histiocytosis. Subsequent plain radiographs of the long bones revealed an appearance consistent with Erdem-Chester disease. So it's a very rare condition. It's a non-Langerhans cell histiocytosis with overproduction of histocytes. It affects people between age of 50 and 70 years with unknown prevalence because of the rarity of the disease. It's poorly recognized as well. Around 54% of those patients will have a BRAF V600E gene mutation, and the most commonly involved site is the skeleton. However, the central nervous system, skin, kidneys, and the cardiorespiratory organs are also involved. The definitive diagnosis is by biopsy, of course, and there will be histocytes in the biopsy, and if it's unattainable, the biopsy, then we should diagnose our patient clinically. The Mayo Clinic Multidisciplinary Histocytosis Workup Group suggested an algorithm for the initial diagnosis with 3 major and 4 minor features, and for diagnosis, they recommended a full-body PET scan, a biopsy of the FDG avid tissue, and testing for the mutation, in addition to staging studies. And ultimately, the presence of central diabetes insipidus with bony pain should prompt an urgent consideration of Erdem-Chester disease and Langerhans cell histiocytosis. How does it confuse us with vasculitis? So around 48% of patients with Erdem-Chester disease will have a periarterial thickening of the thoracic and abdominal aorta, and around 11% will have a periarterial thickening affecting the left subclavian artery. So they may present with intermittent claudication, sometimes ischemia as well. Treatment is usually with interferon alpha in mutation negative patients, and BRAF inhibitor in, if the mutation is present.
2 minutes, Doctor.
Yeah. My last case is about a 43-year-old woman who's referred to the rheumatology with a possible systemic vasculitis. She had a medical history of hypertension and recurrent headache, neck pain, and left arm paresthesia. She's on antihypertensive medications. 4 years ago, because of the persistence of her symptoms, MRA was done, which showed bilateral internal carotid artery dissection and leukoencephalomalacia. She was started on anticoagulation followed by antiplatelet therapy. 2 years ago, because of her persistence of symptoms, an MRA was done confirming left internal carotid artery dissection and stenosis of the right internal carotid artery, which was repaired. Systemic vascular disease was suspected at the time, and the CTA showed string beads appearance of the distal 2/3 of the right renal artery without significant stenosis. And in histopathology, it showed no inflammatory infiltrates or atherosclerotic lesions. And she was stable on antihypertensive and antiplatelet therapy. And this year, because her symptoms got worse, another MRA confirmed the string of beads appearance of the middle to distal part of the right renal artery with significant hemodynamic stenosis that was successfully repaired. For the last 4 years, everything was done, and it showed no atherosclerosis and no inflammatory changes. And that's why the patient was diagnosed with fibromuscular dysplasia. So it is a non-inflammatory, non-atherosclerotic arterial stenosis, which affects 10% of family members with an increased risk of stroke, aneurysm, sudden death, and hypertension. The treatment is usually with antihypertensive medication plus or minus revascularization in certain circumstances. It's worthy to mention that steroid can harm the vascular wall, aggravating the lesion of the fibromuscular dysplasia. Another entity which could confuse us with primary vasculitis and fibromuscular dysplasia is segmental arterial mediolysis, which can be more symptomatic with spontaneous aneurysm rupture. And in this condition, there will be no normal inflammatory markers and no genetic association. It mainly affects the mesenteric artery, unlike the FMD, which mainly affects the renal and carotid arteries. The typical lesion is usually aneurysm and dissection, and the dominant histological feature is usually medial vascularization. There is no effective treatment for this condition, and the optimal treatment is the control of blood pressure. And just to wrap up things, it's very important to exclude vasculitis mimics and secondary causes based on the clinical presentation, and to confirm the diagnosis of vasculitis and assess the extent of vasculitis, in addition to identification of specific subtypes of vasculitis. And here I conclude. My take-home message is that primary vasculitides are rare diseases, generally less common than the secondary forms, and many mimickers are non-inflammatory, so treating with immunosuppressive medications as steroid is not unnecessary, but it's also hazardous. An attempt to establish a diagnosis using the best risk-benefit strategy and therapy is then instituted accordingly. The diagnosis of primary vasculitis should always be reappraised if steroid therapy and immunosuppressive therapy failed. Differential diagnosis of large vessel vasculitis mostly are atherosclerosis and infection, in addition to genetic disorders, and vascular imaging and inflammatory markers are often useful in the evaluation of medium vessel vasculitis, and the clinical presentation of small vessel vasculitis is usually heterogeneous, necessitating multidisciplinary collaboration. Thank you very much, and thank you.
Thank you, Dr. Qatari, for the excellent talk. Vasculitis mimickers is a very long list, and it's really excellent talk. Thank you. It's the time now to move to our third speaker, Dr. Ibrahim Al-Maghlouth. He's a consultant internal medicine, rheumatology at King Saud University. He's an assistant professor at King Saud University too, and he will speak about challenge and Behçet disease. Please, Dr. Ibrahim, the podium is yours.
Well, thank you so much for this wonderful invitation. I promise you a couple of things. First of all, I'm not as good and thorough like my previous honored speakers. And two, I really suck in presentation, so I promise you that hopefully my talk will be more interesting than looking at the slides. So that's what I'm gonna try to do. And finally, I need to catch my flight in 20 minutes, so I'm gonna do it. So let's start. So this is the this is a very important. Yeah. So I think the very important point that I want to highlight is there are a lot to talk about in Behçet disease. And one of the major challenges comes from the heterogeneity of the phenotype or the clinical presentation of Behçet disease. And the second part, which is very important, is the non-specificity of each of the items aside from the genital ulcers. So this is very important to keep in mind, and we'll see how, hopefully, by the end of this presentation, we'll need or we'll hope that we can push for more classification criteria that can adopt more sensitive approach to clinical presentations. Now, of course, I'm going to highlight my methodology, given that I'm a methodologist. So I did literature search, and I did include a lot of papers from Midline. I also used some of the prelim work that we conducted in our center in the field of Behçet disease diagnosis and classification. So, of course, the heterogeneity comes from the specific manifestations. We know that oral ulcer is very common, but also commonest aside from Behçet disease. So idiopathic aphthous ulcer is one of the commonest manifestations. We know that genital ulcer also is an important differential diagnosis and has specificity. Pathergy is a neutrophilic Kupner-like phenomena that can happen in other entity. And vasculitis, as we heard in the previous talk, is fairly widely present in many conditions. Now, oral ocular manifestation is another total ball game, because most of us as a rheumatologist will rely on the ophthalmologist's opinion saying that this look like Behçet disease. And of course, we have the CNS and GI manifestation. Now, what is the implication of this heterogeneity? The implication is really on how we classify someone as Behçet disease. And of course, there's difference between classification and diagnosis, but for simplicity, we want to make sure that when we say Behçet disease for someone, that means that he is similar to most of the people following the same classification criteria. Most commonly used one is the earliest one, which is the International International Study Group of Behçet disease, or ISG, which mandate essentially presence of recurrent oral ulcers in addition to two of the following, which is the recurrent genital ulcers, eye inflammation, skin lesions, or presence of pathogen test. However, there is a challenging part in the sensitivity of the ISG classification criteria. And I will mention it soon, but I had to mention something about pediatric patients because they are awesome, and also because you learn a lot from pediatric populations when they present with Behçet-like presentation. With the consensus classification of pediatric Behçet disease, they made their life easy. Essentially, everything counts with 1 point, and the presence of oral ulcer, genital ulcer, skin, or ocular, neurological, or vascular manifestation also gets 1 point. Scoring 3 out of 6 will classify the patient with Behçet disease condition on ruling out secondary cause. However, the same approach was taken by the international criteria of Behçet disease. The ICPD was more recently developed, and in comparison to the pediatric criteria, they gave higher weight to certain manifestation, particularly presence of genital ulcer, the presence of ocular lesions that is classical for Behçet disease, or also the presence of oral ulcers. They also included other manifestation, including the neurological manifestation, into the classification criteria. Now, the implication for that, okay, well, you need to take my word for it. There was an implication for it, but the implication for that is that the performance of the ICPD classification criteria enhance the sensitivity of the classification, i.e., you were able now to classify someone with ocular manifestation, for example, who did not have most of the other manifestations of Behçet disease. Now, of course, that will be on the downside of that is the specificity. Although in the original study of comparison they had decent specificity, you can see soon that you can misclassify people who tend to have Behçet-like manifestation. And that's most of the focus of this talk. Now, of course, from our study that looked at the patient with Behçet disease in a cohort of 134 patients, you can see that with the ICBD classification criteria, we're able to review the manifestation. Majority had oral ulcers, but their initial, here's the pointer, well, that's not there. That's fine. You can see on the right side figure that the ocular manifestation is one of the main initial presenting features of the disease. And why is that important? Because we tend to have a referral center from of King Abdulaziz University Hospital, which is an ophthalmology center, and we tend to see a lot of the ocular manifestation of Behçet disease. So that's a very important point to keep in mind, that you can, with the ICBD, expand your classification of patients with ocular manifestation who tend to have less of the other manifestation and include them in your cohort. However, the implication of that is very important as well when you have unusual presentation. And most of the talk today will be on the unusual presentation or unusual feature. Are they Behçet related or not? So the first one comes from a patient, 28 years old, who's originally from Sudan, who had been treated previously with TB and presented with recurrent oral and genital ulcer. He was diagnosed with Behçet disease, which was appropriate based on the both criteria, ISG and ICPD. Furthermore, the patient was controlled on colchicine, then he was switched on anti-TNF, on Imuran, and then anti-TNF, and he was fine. Then he presented with recurrent fever at the early phase of his start of initiation of anti-TNF. This fever was associated with some pleuritic-like pain, and he was found to have serositis, pleural effusion, and pericardial effusion. So the debate that we had in that time is serositis part of Behçet disease presentation? Because it's not a common manifestation. We don't see it in the classification criteria. Is it part, or there's something else that we are missing? And the debate goes on, and we are an academic center, so we love to debate. But we decided to go to another route and actually conduct a systematic review on an individual-based data, looking at all the case reports and cohorts that has been published on Behçet disease that included serositis as one of the manifestations, whether pleural, pericardial, or peritoneal involvement. And you can see we identified 44 patients who had been described as Behçet disease. Most of them meets classification criteria. And in all of those patients, you can see that they actually fulfilled the classification criteria, but in addition, they had some sort of serositis. Most common was pleuritis, followed by peritonitis and pericardial effusion. Most of them, at their presentation of serositis, had elevated inflammatory markers, and they also 50% of them had fever. And this is a very important point. Now, what about the causes of these serositis? When you look at the causes in these cohorts, you will find that 68 of them were attributed to Behçet disease. I have to warn you that the quality of the case reports was low to moderate. So we had good moderate numbers. We don't have high quality numbers based on Newcastle modified criteria for assessing quality of case reports. Furthermore, 20% of them had actually secondary causes, and on top of the secondary causes, you will see tuberculosis. You had also FMF, and you also had anti-TNF related. So in our case, patient was early initiated on anti-TNF. It could be anti-TNF mediated lupus-like presentation. However, antihistone antibodies was negative, and the fever continued despite discontinuation of anti-TNF. We also did our due diligence and sent for blood workup and samples from the fluid, and it turns out that the patient had recurrence of his TB as a reason of his presentation. That being said, still 60% of patients in these case reports, systematic review, was found to be Behçet related. Why this is important? Because the third question that you will ask yourself, what is the outcome of those patients? And in almost 9 to 10% of the patient, mortality was present. So this is a very serious mortality rate in a group of people who present with Behçet disease and serositis. That could be related to the delay of diagnosis or the inability to recognize secondary causes. And this is very important. Now, of course, 15% had recurrence, and some of them after the treatment has flare-up, but the majority responded well to the treatment of the underlying etiology based on the graph I mentioned. So now with serositis, we can recognize that some unusual presentation can happen even if they are not in classification criteria. Second question is, so do we have a role for familial type of Behçet disease? Does the family history matters? Do we need to ask a patient? Now, of course, we need to ask a patient, but you can see that in the previous reports of Behçet disease, international large cohorts did not show significant association between family history and diagnosis of Behçet disease. To replicate that in our cohort, you can see that the presence of family history was not significant in most of the patient. And that's reassuring. Why is that? Because when you have patient with Behçet disease, you will ask and strong family history, you will ask yourself two questions. First of all, is that Behçet disease or Behçet mimicker? And two, would that respond to usual treatment? You can see in this table that the presence of family history did not defer the response to advanced treatment like anti-TNF. So do we have a familial type of Behçet disease? This is a patient who had a 24-year-old lady with recurrent episodes of oral ulcers, history of genital ulcers. She also had very strong family history of similar presentation. She had some episodes of recurrent infections in the form of upper respiratory tract infection and UTIs in the last 3 years. Her exam was unremarkable aside from acne-like lesions, in addition to her history of oral ulcers, and her inflammatory markers were slightly elevated. So what are we dealing with? To make the story short, we have a couple of conditions that can present with a strong family, with a Behçet-like presentation and strong family history. One of them is recently described haplotype insufficiency of A20 enzyme. This enzyme is involved in the degradation of ubiquitin protein that is attached to molecules down the stream of the TNF stimulation, and it's considered part of the NF-kappa B immune dysregulations. The results of the enzyme defects, essentially an increase in NF-kappa B signaling, and as a result, increase on the IL-1 and the TNF release. Patients tend to present early in childhood, and of course, I'm not gonna take the discussion on a pediatric case in the presence of the wonderful, astonishing, and well-known speakers here in the audience. But the most important part that those patients tend to have a history of recurrent infection sometimes. They can have a positive serology, including double-stranded DNA, and including low complements as well. They have the features of Behçet disease, but more importantly as well, you will see that they tend to have very strong family history. They also can be inherited as an autosomal dominant disease. So that patient was sent for whole exome sequencing, and she was found to have a haplotype A20 insufficiency. Now, the other form that I want to highlight in terms of the history of familial Behçet disease, or in unusual presentation and presence of lymphadenopathy. So a 30-year-old lady from Yemeni who lives in Qasim. I'm not sure why I mentioned she lives in Qasim, but we love Qasman. And essentially, she had a history of recurrent episodes of fever, lymphadenopathy, oral ulcers, and skin rash. Skin rash was acne-like rash, and she had also inflammatory arthralgia or question mark arthritis, because I did not see it when it was swollen in the past. She had these episodes recur with fever and lymphadenopathy, and she also had some tonsillar enlargement. And the biopsy showed non-specific non-granulomatous, non-specific inflammatory changes that was suggestive of reactive features. Her other secondary screening for infection and other etiology were all negative. So the question is that Behçet? And she was labeled with Behçet disease. Now, of course, the presence of lymphadenopathy can happen with Behçet, but it's not classical. And her story goes back to early teenager time. And these episodes of fever and lymphadenopathy was also associated with some elevated inflammatory marker and enlargement of the tonsils on physical exam. All of these can fit something called BAF syndrome, so periodic fever after stomatitis, pharyngitis, cervical lymphadenopathy, and these patients, if you look at the Euro fever classification criteria, they are considered one of the recurrent autoinflammatory conditions. They tend to have, in the criteria, you need 7 out of 8 to classify the patient, and you can see that the mimicry with the Behçet disease is high. But the key part is the presence of lymphadenopathy, tonsillar enlargement, in addition to oral stomatitis and arthritis. This should prompt us thinking of BAF syndrome. Patient did well, responded well to Imuran, and she is happily ever after. Now, in addition to that, further studies was looking for the monogenic type of, looking for the familial history of Behçet disease from a genetic perspective. So this is a very nice study that was published on young individual who present with Behçet-like presentation and has been sequenced and was found to have monogenic forms. Monogenic form in Behçet disease, in addition to, as I mentioned, haplotype insufficiency, which is important, is the presence of TNF-alpha induced protein or regulator protein mutations, and these are very important in the presence of their defect. The release of TNF will be increased, or the activation of TNF will be increased and uncontrolled. And this is very important to keep in mind, because those patients will likely respond very well to anti-TNF rather than the other agents of Behçet disease. Finally, and this is very unique because I'm also part of the international group that looking into those patients, presence of hematological abnormalities. So many occasions, patients with skin rash, oral ulcers, and joint pain might have significant hematological abnormality in the form of cytopenias. Anemia is major one, macrocytic anemia, in addition to other white cells lineage drop. And this is very important because many of those patients may have other inflammatory conditions like relapsing polychondritis-like presentation, polyarthritis-like presentation, or skin rash or vasculitis, skin manifestations that we tend to have with T helper 1 pathway, SPA, Behçet-like, which is include erythema nodosum, sweet syndrome, so all the neutrophilic infiltrative dermatological manifestation. Now, of course, this condition is called VEXAS, and VEXAS syndrome is a recently recognized or more recognized condition that is characterized by vacuoles in the bone marrow associated with mutation in E1 enzyme, which is enzyme important for the degradation of ubiquitin protein. These are coded on X-linked, so that's the X in VEXAS, and they are associated with autoinflammatory, so fever episodes, and they are somatic in mutation. That means that they can be acquired throughout life. So many of those patients can be in their midlife or later in life. And of course, there are huge efforts worldwide to recognize those patients. IDA network is an international network that I was fortunate to be invited to join by Prof. Al-Mayouf. And there is the protocol of BAFA was published, and they are currently collecting and recruiting patients. So we welcome everyone who has some patients to send the patient to our cohort. In summary, I'm finishing on time. I love myself. In summary, it's very important to recognize different presentation of Behçet-like mimickers. Behçet is an important diagnosis, but presence of unusual manifestation require you to think about secondary etiologies. Presence of serositis, lymphadenopathy, very strong family history. All these things are not usual, so just think about secondary causes. So that's number one. I think we are underutilizing whole exome sequencing and genome-wide studies. They are becoming more publicly available, much cheaper. We need to do that because you will be surprised at the amount of findings that you will find in these studies. And finally, collaborative work are needed to enhance our understanding of unusual presentation. And with that, I conclude. On time. Love it. Okay.
Thank you, Dr. Ibrahim. You did it exactly on time. So, yes. Yeah. What about the questions? Huh? Okay.
It's okay.
Yes. Okay, so our last talk in this session, we would like to invite a guest, a neurologist in the house. So welcome Dr. Salman Al-Jarallah, consultant neurologist, assistant professor in King Saud University. He's going to talk about challenges in primary CNS vasculitis.
Assalamu alaikum jami'an. Thank you for the introduction, and thanks to the organizing committee for the invitation. It's gonna be, I like the fact that you put the neurologist at the end of the talk. I don't know what does that mean, but I hope that means you guys are going to be more interested in hearing the talk. I'm sorry if my talk is the talk that's between you and the lunch, but I'll try to be fast and quick and hopefully useful. So I specialize in neurology and immunology, so we tend to get referrals for different CNS inflammatory disorders, including vasculitis. So I have no disclosures for this talk. We're going to be talking about the introduction about CNS vasculitis, primary CNS vasculitis. We're going to be talking about the challenges that we usually face, causes and mimics. There's probably every talk about vasculitis you hear about mimics. The criteria that's been used to diagnose CNS vasculitis, approach to the diagnosis and the treatment, and the outcome of those cases. So as you know, as the name says, it's primary CNS vasculitis. Some people call it primary meningitis of the CNS. It's a disease that affects primarily the blood vessels of the brain, spinal cord, and meninges, with little or no systemic inflammation or systemic cause or no identifiable cause. So whenever we find the cause, it's not primary CNS vasculitis anymore. The condition is rare, and this is why it's challenging, and it's poorly characterized. And this is why it's challenging to diagnose and also to treat. Without biopsy, we always have to be careful. And then we have to talk about demographics. This is a condition that typically affects people from the age of 20, 30, up to 60. When they did studies, most of the patients were around the age of 40. And typically in the literature, they would tell you this is a condition that affects males more than females, although there's not that much of a difference. As the title of the talk says, there is a lot of challenges in this condition because of its rarity, meaning that there is going to be not a lot of evidence in terms of diagnosis, hardcore evidence for that guides treatment. The estimated incidence based on studies in 2007 is about 2 to 4 in 1 million. And it's a serious condition. So sometimes, yes, we cannot diagnose a lot of condition, but they can be not serious, there's no treatment, so we're kind of comfortable. However, this condition is serious, can lead to disability and even mortality. The other challenge is the heterogeneity of the presentation. So different patients come with different presentations, which makes it difficult to identify and diagnose. And of course, the mimics, which going to be, already Dr. Safi spoke about early on. I'm going to comment on a few of them. And sometimes those mimics also can be serious, such as neoplasms or serious infections. And the problem, even when we do our best, we suspect the disease, the tests that confirm the diagnosis are not that sensitive and not that specific. And the brain biopsy, which has been termed as the gold standard to the diagnosis, is invasive. And even when you go on and do it, sometimes you're going to come back with an inconclusive biopsy. And of course, you are familiar with the treatments and the potential side effects and the fact that there is no good biomarker for diagnosis and follow-up or prognosis. So before we go to primary angiitis of the CNS, we have to talk about secondary vasculitis. This is a slide for why we call rheumatologists. When you saw those patients, it's basically to help us finding those diseases. And sometimes the vasculitis is not a primary disease in that condition. It can be secondary, and you guys are familiar with those conditions. And a very rare but important differential is malignancy. Sometimes lymphomas can present only with vasculopathies, which is rare but serious. And of course, drug and toxic, like illicit drugs, drug of abuse, and infections, which Dr. Savi have already mentioned a few of them, which are very important etiology and probably more common cause than primary angiitis of the CNS. This is the slides where neurologists should be helpful to you when you have a case. These are the different cases that can cause vasculopathies without significant inflammation, and it might look like vasculitis. So whenever you find a neurologist call you, this could be angiitis of the CNS, you have to ask them, is it not atherosclerosis, is it fibromuscular dysplasia, CADASIL, moya disease? These diseases are not that rare. Yes, they're not that common, but also they're not that rare. And the first condition here is the reversible cerebral vasoconstriction. It's a very important mimic, especially when you diagnose vasculitis based on angio only. Dr. Safi already spoke about fibromuscular dysplasia. This is a slide of, this is a picture of a string of bead signs. It's actually a renal artery, but I kind of flipped it to make it look like a carotid. And then on the left side, this is a moya disease, which is very common. Sorry, it's not very common. It's not uncommon, I would say. It can be primary. It can happen in any patient who have stenosis of the entire carotid artery. You would see, I don't know if I have a pointer. Yeah. So, yeah, going to be what we call the puff of smoke, this blur of blood vessels. This is a typical moya disease, which can look like vasculitis and can present like vasculitis. So the diagnostic criteria that have been used to diagnose primary angiitis of the CNS have not changed since 1980s. It requires the presence of unexplained neurological deficit, so we really have to do a good workup to exclude other etiologies, and then you need a brain biopsy or angiogram. Of course, without finding any other cause such as infections, inflammation, etc. So basically, you can diagnose primary angiitis of the CNS without brain biopsy. And this is probably one of the sources of the confusion in the literature. So the presentation can be variable. They can be strokes, chronic meningitis, someone who presents with a headache, and then you do an MRI and you find leptomeningeal enhancement. Sometimes for lucky patient, they might present with tumefactive lesions. I say lucky because that's usually an indication for biopsy and easy to get a biopsy, and then you get a diagnosis faster. Sometimes all what you have is a headache with some abnormality in imaging. However, if the headache is severe and sudden, this is a red flag for vasculitis. This is usually suggestive of something called RCVS. And some patients present with cognitive impairment or seizures. So you can see the presentations are wide and variable. So this is a meta-analysis that I'm going to refer to in the few slides. It's probably the largest meta-analysis in the topic. It's been published in 2021. I recommend everyone to go to it whenever he wants to know more about the disease. They tried to look at all the case series that included 2 patients or more in the last 20 plus years. And they ended up finding about 900 patients, so it tells you this condition is pretty rare. And they found that the most common presentation was focal neurological signs, hemiparesis, headache, and cognitive impairment. So when you go to see the patient, you're going to do your usual history and examination, focusing also on travel, hobbies, drugs, sexual habits, and then family history of genetic vasculopathy, which is actually, it sounds easy, but it's very commonly, unfortunately, underused, underutilized, and sometimes missed. And then you're going to do the skin examination, looking for any typical signs or rashes or vascular changes. Of course, the eye, as Dr. Safi mentioned earlier on, that it's an extension of the brain, so we recommend that patient with suspected primary angiitis of the CNS to see a ophthalmologist even if they have no symptoms. It can be a clue to other underlying etiologies. So what investigation you would do? In the literature, most people have recommended doing like a thorough workup before calling this as a primary angiitis of the CNS. And most of the criteria, at least used in research, they added this as kind of an exclusion criteria by having any of these workups positive. So echo and Holter have to be done. blood culture looking for infective endocarditis, whole body imaging, immunologic testing, at least ANCAs and ANAs, infections looking for HIV, hepatitis B and C, and tuberculosis, syphilis and varicella zoster, in addition to a workup to exclude malignancies. So it's almost like a diagnosis of exclusion. So I guess when you get a consult for a patient with possible primary industrial CNS, you really have to make sure the neurology team have done their diligence, have done a good workup. And then the spinal fluid. A lot of us believe that spinal fluid is one of the best diagnostic tests for this disease. However, it might not be as good as what we think. And this meta-analysis, they found that up to 70% of patients have abnormal CSF, which is meaning elevated protein, basically. However, 30% of them have normal protein. And as we know, elevated protein is not really specific for any disease in the brain, and it just tells us that there is something going on. Having cells in the CSF is usually indicative of inflammation. Having too many cells, let's say 400, 500, that's possibly what suggests infection. And then the main goal of the CSF testing is to look for infections. And this is an important consideration, looking for syphilis, like Dr. Asafi's case, varicella zoster, aspergillosis. And nowadays, there is a more and more interest in doing what they call a metagenomic next-gen sequencing, where you take the CSF and just look blindly for any DNA in that CSF. And there have been case reports of cases called primary industrial CNS, where it turns out that this is actual infection that is very rare and never tested. So this might be something that we do in the future routinely. There is ongoing research trying to find the pathogenic mechanisms. They found some dysregulation in the complement pathways in people with primary industrial CNS, and they found interleukin-17 elevation, which is also not specific for meningitis. It tells us there is an inflammation. So these are not usually done clinically nowadays. So the CSF is good, but not that exclusive. So then you go to do neuroimaging. So neuroimaging is probably the most sensitive test you can do to diagnose CNS vasculitis. 98% of patients did have abnormalities. We were talking about infarcts, hemorrhages, and sometimes enhancement in those lesions or the leptomeninges, although this is not that common. However, this is a very important slide because it's a very common misdiagnosis, very common overdiagnosis of vasculitis, very common referral to you guys and to us is non-specific white matter lesions. Nowadays, we do a lot of MRIs, and even in healthy people, you're probably going to see these spots. And usually, the radiology report is going to say something like there are white matter changes. This could be ischemic, could be vasculitis, could be demyelinating. And this is usually where patient gets referred, and they might end up having extra workup. These are completely normal and can be seen in completely healthy people unless you see diffusion restriction, meaning this is acute ischemia, or if there is enhancement with contrast, or if there is change in the blood vessel. So be careful when you get a report with these non-specific white matter changes. So then we do the angio, which has been one of the two tests that used to diagnose vasculitis per criteria. We look for the classic beading pattern where you see that narrowing and dilatation blood vessels is usually smooth and sometimes can cause occlusions. And it has to affect multiple cerebral arteries. And in most of the studies in the literature, they tend to exclude patients who have atherosclerosis. So in real life, it can be difficult. You might see typical changes of vasculitis, but then you see some atherosclerosis. So in real life, sometimes you'll have to include those patients as vasculitis. However, in the literature, they have to exclude those patients. So it's good to look at the lumen of the blood vessels. However, again, conventional angio, whatever you see, is not always specific for CNS vasculitis. There are a lot of mimics, like we discussed earlier on. This is the patient with endocarditis, bacterial endocarditis, who did have like narrowing dilatation similar to CNS angiitis. And this is a patient with reversible cerebral vasoconstriction who also did have stenosis and narrowing. And when they looked at all the cases being published in the last 20 years, it was very interesting to know that the DSA was positive in only 30% of patients with biopsy-confirmed vasculitis. So there's a huge discrepancy. And when you take the people who had positive angiogram and they do biopsies, it's only 8% that came back positive for biopsies. So that tells you there's a lot of discrepancy. So that's why I guess we need to have better diagnostic criteria, better stratification of cases. So now we come to the vessel wall. I'm sure you probably have seen patients who had abnormality in what's being called vessel wall imaging. This is kind of a new technique in MRI, requires a 3 Tesla MRI with contrast, and you can see on the left side, there is, the left side of the brain usually in the right-hand side. So you can see the enhancement around the blood vessels, the hyperintensity. This is abnormal. This indicates inflammation. So this is very nice, looks very nice. It looks easy, and it's kind of suggestive of vasculitis. However, the pattern of enhancement can be also seen with atherosclerosis. So this is also another problem. However, it tends to be more eccentric, asymmetric on the side, not concentric. So when you see concentric, diffuse, symmetrical, this is more vasculitis. Eccentric tend to be atherosclerotic. So you really have to have good radiologists, experienced radiologists, to tell you this goes more in favor of vasculitis or more in favor of atherosclerosis. So this is an example of patients on the left-hand side who had stenosis in the angio, and then he had positive vessel wall imaging on the left side. They treated him cyclophosphamide. The stenosis persisted, but the contrast enhancement improved. And this is another example of COVID-19 vasculitis, and which also improved. It's also confirmed by angio, by MRI of the vessel wall. So it's helpful to use this technique to differentiate inflammatory from non-inflammatory cases, and it's also helpful to guide us in the biopsy, take the biopsy sites, and to do the follow-up as in the case we saw, although this has been controversial. It does have limitation, as we said. Atherosclerotic lesion do have some inflammation, so you might see enhancement. So you have to be careful. Then we go to the diagnostic test of choice, which is the brain biopsy. So you don't know what's going on. You want to confirm it. You want to go for brain biopsy. So some experts in the field, they recommend doing biopsy for everyone, and the rationale is that you're going to treat them with some toxic medication. Probably the risk of the toxicity outweigh the risk of biopsy itself. It does confirm the diagnosis, and it also helps to exclude important mimics, infections such as syphilis, neoplasms, such as lymphoma. However, there is also limitation. It's invasive. It's obviously invasive. There's a risk of hematoma at the site. Usually it's mild. It's not that severe. And there's 1% risk of disability. And the main problem is the sensitivity. So even when you do your diligence, you do the biopsy, the surgeon takes the biopsy, the yield is not that high. Studies have shown that about 38% of patients would have negative biopsy, despite they have typical classic presentation. And even some of these negative cases, when they passed away and they did the autopsy, they did find the diagnosis to be vasculitis at the end. So it tells you there is a problem with sampling. This is what you call sampling error. And probably because of undersampling the meninges, the brain, and sometimes the surgeon has to go to an area where there's no imaging abnormality. So this is usually us nowadays, most of neurosurgeons would not go to biopsy healthy tissue. They would insist to go to an area which is abnormal. So some authors suggest that the ideal biopsy should be 1 cubic centimeters with the gray and white matter, leptomeninges, and cortical vessels. This is something you can tell the neurosurgeon when he does the biopsy. I mean, 1 cubic centimeter might sound small, but I have to tell you, like the brainstem itself is like 2 centimeters at length. So it's large to take 1 centimeter, cubic centimeter from the brain. So then what do you see in pathology? Typically, the classic primary and rest of the CNS is granulomatous inflammation. You can see the granuloma at the lower part, which is the commonest type. Sometimes you see necrotizing, aggressive inflammation in the blood vessel wall, and sometimes you see only lymphocytic infiltrate, and this has been associated with a better outcome. If you stain for amyloid, you might see amyloid staining, which has been seen in different types, like granulomatous, necrotizing. The implications of that are not clear. Okay, so you did your diligence biopsies, and there's no diagnosis. So don't worry, you're not the only one. This is Calabresi. He's a rheumatologist. He's the one who made the guidelines. Who said that it's often that you're not going to reach the diagnosis. You're not going to be comfortable. This is a different diagnosis. At that point, you will treat and then do a meticulous follow-up. So treatments, as I think we already spoke about treatments early on of secondary systemic and advanced colitis. In primary angiitis, as you might imagine, there's no clinical trials. Only what we have is anecdotal evidence, observational data, and it's mostly from the secondary systemic vasculitis literature. So usually treatment is more similar. You go induction, steroid, cyclophosphamide, maintenance, steroid tapering, steroid sparing agent with or without steroids. And this is when they looked at all the patients, the 900 patients. So they noticed most of them received steroids, usually oral, 1 milligram per kg, over variable periods, up to a few years, and they would sometimes give them pulse. Most of the patients received cyclophosphamide pulses, up to 12 pulses, like 12 monthly doses in some patients. And then some people, they try to induce with Imuran, Cellcept, or rituximab, or methotrexate. Maintenance treatment is also variable, more or less similar to secondary angiitis of the CNS. And some people have used rituximab also, like systemic vasculitis, ankylosing. There are also weak evidence in primary angiitis of the CNS. And in 2 refractory cases of primary angiitis of the CNS, they've used infliximab and etanercept with good success. So what happened to those patients when they followed them? The French cohort of 112 patients, they followed them for a median of 57 months. They found that 95% of them achieved initial remission in the first year. And however, 40% of them had relapses during their follow-up period. The mortality was 8%. And they noticed that people who stayed on maintenance therapy had prolonged remission and better functional status. The American cohort of Mayo Clinic, the mortality was a bit higher, like 15%, and relapses were higher. And they tried to look at patients who passed away, and they tried to do stratified logistic regression analysis, and they tried to identify a risk factor of mortality. They noticed that older age, diagnosis by angiography only, not biopsy, having a stroke or having large vessel involvement being associated with worse outcome and mortality. And by that, I summarize my slide by saying the diagnosis cannot be made with certainty without biopsy or typical angiographic findings. So any case you have been labeled as primary angiitis of the CNS without biopsy, without typical angiography, you have to revise the diagnosis every time. And mimic secondary causes have to be extensively worked up and discussed with the neurologist, other non-inflammatory etiologies like genetic etiologies, stroke mimics, etc. And even if you're not sure, you have to revise the diagnosis every time. And then I think this is a problem with our busy practices. We see the patient follow-up, we say, okay, he has vasculitis, how are you doing? Next. So we have to, every time we see them in clinic, we have to think again, go back. Is it really vasculitis or not? And of course, most importantly, and this is one of the reasons why I'm here, is that we have to be multidisciplinary, discuss with neurologist, discuss with rheumatologist, radiologist, neurosurgeon, infectious disease specialist, pathologist, all have to be in the same page. And I think in those cases, it's always good to take second opinion on everything, because sometimes you get enlightened by hearing other people's opinion. And by that, I conclude. Thank you very much.
Thank you, Dr. Salman, for the excellent talk. And now we'll move to Q&A session. Start by questions.
نبدأ بالدكتور عرفج. عبد الله.
Thank you very much. Excellent talk for all speakers. Thank you. Congratulations you. My question for Dr. Abdullah Al-Mutlaq. يعطيك العافية. شكرا على المحاضرة. Just for critical organs, life-threatening organs, when we do induction, one of the most drug that is proved to be effective is for induction and maintenance is the rituximab. So how reliable is treating patient with rituximab biosimilars? Because this is currently, I think it's the most available in our institutions.
Okay, so it is available. The guidelines recent last year in ACR and also the EULAR, which is not published, they did not allude to it a lot. So still in terms of evidence base and recommendations, and it's still not alluded to it a lot. So it is not included in the guidelines yet.
We have another question there.
Thank you very much for all speakers. Great session. My question for Dr. Abdullah. Dr. Abdullah, we know that ANCA is pathogenic in ANCA-associated vasculitis. So why do you think plasma exchange is not working? And when do you think we should use it?
So plasma exchange, as mentioned back in 2007 when the MEPEX trial was introduced, it showed only a slight significance up to 12 months only. And when they followed up the patients up to 4 years, they were not able to have a clear statement of how plasma exchange is beneficial. It is recommended for patients with high risk for end-stage kidney disease, yes, for anti-GPM, yes, but pulmonary hemorrhage, as the PEXVAS trial, it is not recommended to go only for patients with pulmonary hemorrhage.
I have a question for Dr. Salman. Is there any role for PET nuclear scan and diagnosing or monitoring patient with primary CNS angiitis?
PET scan. PET scan has been used initially as diagnostic way to exclude other diseases. In the brain, PET scan is difficult. Usually, you wouldn't see a lot of inflammation because it's very small. The area is very small, the CT scan blood vessels are very small. So I haven't seen anyone who used it as a way to monitor or to diagnose even. So I didn't see it as only a way to rule out other systemic involvement. So been, the only thing is sometimes we have tumefactive lesions, like vasculitis presenting as tumors, like lesions. And those cases you might have a value of doing PET scan. But if it's just vascular changes, it's going to be difficult.
Yeah, thank you for all speakers for the excellent, outstanding lecture. For my question to Dr. Jarallah regarding CNS biopsy, brain biopsy, when to consider it, at which stage? Because always the patient afraid, the neurologist or they used to refuse to do it. So what is the advice and what is your experience from the outcome of the biopsy?
You're talking about the biopsy, right? Yes, so I understand here when there's a different perceptions. In our country, here in our culture, it's not easy to do biopsies in the brain, especially in this condition, because usually the brain is kind of normal. Other than the areas that are affected, it's not that bad. There's no severe damage, so it's always difficult, the biopsy discussion. If you exclude everything, you find that there is like no other systemic cause, there's no infection, nothing, and then there's a plan to start on treatment. I think biopsy is warranted, and especially if the angiographic finding did not fulfill the criteria. If you have angiography that shows the criteria, then yes, you might say we can go on with that biopsy.
But from your experience and the outcome of the biopsy, because sometimes we know that more than 50% it's useless, the result. So from the case you have seen, how common or what is the percentage of positive CNS vasculitis from this? And
what's the percentage of?
Yeah, the positive evidence of vasculitis for a patient with primary vasculitis.
And vasculitis, it's not that high, unfortunately. Yeah. Even if you do the biopsy, it's not like 80%. Yes. If you look at different studies, some of them say it's 70%, 80%, but you look at the meta-analysis, it's 30% that had positive biopsies. And probably because some studies are from like many years ago, and the biopsies were not as good, and not as selective, and not as large. I think nowadays with the better techniques in MRI, MRA, vessel wall, you're probably going to do more targeted biopsy. But you need to take cortex and you need to take meningeal blood vessels. The difficult part when you have a lesion that is in a sensitive area in the brain, let's say around the brainstem or around the language area. Sometimes this is not going to be possible to do biopsy, and this is probably one of the times where you're probably going to treat without biopsy, which is not ideal. But even if you look at the literature, in those case series, there are patients who were treated without biopsy or angiography. But this should be the exception.
Thank you.
There is a question there.
Thanks for all the speakers for the interesting talk. My question, I have a couple of questions for Dr. Salman. What about spinal cord involvement in primary CNS small vessel vasculitis? Yes. My second question, do you treat large vessel vasculitis, primary CNS first attack, whom they are non-progressive? And I guess the biopsy usually then for small vessel vasculitis rather than for large vessel vasculitis. I'd like to hear from you. Thank you.
Yes, the first question was about, remind me, the first one?
The spinal cord involvement.
Yes, spinal cord. Yes, it's well reported, well known that vasculitis, primary sinus vasculitis can affect the spinal cord, which is probably going to be very challenging to treat and diagnose because for multiple reasons. Biopsies of the spinal cords are difficult, even more difficult than the brain, because usually the spinal cord, it's not that severely affected in those patients. We tend to do biopsy of the spinal cord when there is significant disability. So then, okay, so there's nothing to lose. And then the blood vessel imaging is not also as easy as the intracranial vessels, but it does exist, and it's better when you do the spinal cord biopsy, it should be limited more to the meninges, because the meninges are usually easier to biopsy and sample, but it does exist. The second question is about progressive and non-progressive. So unfortunately, there's no clinical trial. So we really don't know what happens to those patients when you don't treat and then you just wait compared to the one who you treat. So this is the ideal answer will be to do a trial, compare the two groups. Based on the recommendation of the experts is that we should treat when we make the diagnosis, at least with induction. You can see some in the literature, there are patients who were treated with induction only without maintenance. And they notice if you treat these only with induction without maintenance, there is a higher risk of relapse. So based on that, it's usually when you diagnose it, especially if it's a large vessel it tends to be a bit more aggressive. Large vessel vasculitis you treat and then with induction. كان في سؤال ثالث على large vessel also. Yeah, the biopsy.
Doing biopsy in a small vessel rather than large vessel.
The criteria, the diagnostic criteria are clear. You can diagnose vasculitis without biopsy. If you have typical angiogram, yes, you don't need the biopsy. But you have to be very diligent on the angiogram. You have to look at with the radiologist, did they have atherosclerosis? Is it multifocal? If you want to diagnose without biopsy, you really have to do diligence in the rolling out other mimics, especially the irreversible cerebral venous constriction. It's very common. So when you diagnose without biopsy, you should do follow-up angio in at least 3 months. If there's changes resolved completely, then probably you're not dealing with vasculitis. You're dealing with RCVS. So yeah.
Last question, Dr. Hussein. Thank you very much for all speakers. Dr. Salman, is there any difference between the conventional angiogram versus MRA with gadolinium?
Yes. So far, for now, the MRA with gadolinium, you mean the vessel wall imaging? Yes, there are differences. The MRA with gadolinium, it only looks at the vessel wall itself. It's not good for the lumen itself. So for the luminal imaging, we should do the angiogram. So this is a superiority for the angiogram. Also, if you want to look for kind of a smaller distal blood vessels, probably the angiogram, the conventional angiogram is better. The question is, if someone has typical changes in the MRA, would you do angiogram? That's, I think, is going to be case by case. I'm sure there are cases where you'd be very comfortable diagnosing it without having an angiogram. Although, by criteria, which is in 1990s criteria, you have to do angiogram. So that's why I think there is a need for a new criteria that include the MRA vessel wall and maybe lumbar puncture.
Last question, أنا واسطة من عبد الرحمن.
Dr. Fahid, last question.
Okay, last question, Dr. Fahid.
Mike.
So the last question for Dr. Asafi. You show us the causes of the mimickers for the vasculitis. You discussed about the infection. So just my question is, what is the other causes can be mimic the vasculitis, other than infection that you discuss about it?
So other causes, there's infection, there's malignancy, of course, and there are genetic disorders that could mimic vasculitis. There's medications also that could, medication causing vasculitis that could mimic vasculitis as well. Like cocaine, for example, like hydralazine, which is an evolving medication that we all know.
I think he meant what other infection other than syphilis, TB? What is the commonest, like viral?
COVID-19 is a famous one nowadays, and there are for sure herpes zoster infection, herpes simplex infection, mainly viral infections like EBV, CMV, parvovirus B19, Kawasaki. All of them can lead to a picture mimicking vasculitis, and treating the underlying infection is the ultimate treatment later on. Fungal infections are famous as well, and sometimes we don't know the diagnosis unless we examine the patients post-mortemly. However, we don't have this here. So sometimes we miss the diagnosis here.
Thank you, sir.
Okay. By this, we conclude our session. Thank you all for attending. Thank you for all our speakers. Thank you.
شكرا جزيلا دكتور عبد الرحمن ودكتورة سعدية. أدعو دكتورة حنان ودكتور فهد لتكريم المتحدثين في هذه الجلسة. البداية مع دكتور عبد الرحمن الراشد. ثم تكريم الدكتورة سعدية عبد الكريم. الدكتور عبد الله المغلوث. الدكتورة صافي القطري. ثم الدكتور سلمان الجار الله. شكرا جزيلا. الآن أخواني وأخواتي الله يعطيكم العافية، استراحة غداء، ثم نعود عند الساعة 1:30 لاستكمال جدول أعمال اليوم الأخير من المؤتمر التاسع لأمراض الروماتيزم. السادة والسيدات، ندعوكم إلى القاعة لاستكمال جلسات المؤتمر. ندعوكم إلى القاعة حيث ستبدأ الجلسة التالية بعد دقيقتين من الآن. بعد الساتلايت سيمبوزيوم في عندنا ساتلايت سيمبوزيوم هنا لين 51 من 51 يعني نص ساعة. أي. نص.
لا نص ساعة نص ساعة.
لا هذا الكلوزنج.
يعني من هنا إلى هنا.
لا من هنا إلى هنا.
مو نص ساعة.
إلا من 51 إلى 22.
نص ساعة.
نص ساعة نعم.
كثير يا أخي.
لا عادي بالعكس يختصر. نبي نمشي.
صدق؟
اي والله.
يا كذا حرام عليكم كذا. مجهز لي 3 شهور.
الله يعطيك العافية.
أنا حسبتها إلين 12 إلى 3.
البرزنتيشن أطول من كذا أكثر من نص ساعة.
أنا ممكن أخذكم 3 ساعات.
لا كذا الناس بتزعل علينا.
شوف شلون؟ من 13 إلى 14:50. ساعة كاملة.
غريبة.
بس حلوة كذا نص ساعة.
نص ساعة طيبة.
يعني أرقص.
الله يعطيك العافية.
بسرعة.
Ladies and gentlemen, welcome back again. Now let's move to Satellite Symposium, sponsored by Sandoz Company with Dr. Walid Hafez.
طيب بسم الله الرحمن الرحيم السلام عليكم ورحمة الله وبركاته. Pleasure and an honor again to stand here before you to present a few slides on biosimilars. I would like to thank colleagues in Sandoz for this kind invitation and sponsoring me to present this satellite symposium. So over the next 15 to 20 minutes at maximum, I'll be presenting to you the following objectives. So, history of biosimilars. Then I will be explaining to you the concept of interchangeability in biosimilars. And then I'll be walking you through the translation of the totality of evidence into clinical practice, concluding with some real world evidence, as well as our clinic cases supported by the clinical trials that we have in this manner. So starting with the first part of this presentation, history of biosimilars. So what is basically a biosimilar? So both the European medicine agencies as well as the FDA stated a very clear definition of a biosimilar, in which they mentioned that it's a product which is similar to a biological medicine product from all perspectives. Analytical perspective, pharmacokinetics perspective, pharmacodynamics perspective, as well as clinical characteristics and efficacy and safety as well. So the biosimilar now is is implemented actually in the guidelines and the recommendations for the management of several rheumatic diseases. And to summarize both definitions by the European Medicine Agency as well as the FDA, so it says that biosimilars are those products that are highly similar to the reference biologic product based on the submission of quality, safety, and efficacy data. So in another word, biosimilars are another version of the biomolecule of the original medicine. If we go back into history, so the invention and the introduction of biosimilar started almost like 20 years ago, where the European countries initiated a draft that is responsible for the general guidelines that were adopted in the field of biosimilar. Then, as you can see here, that in 2006, Sandoz actually launched like the first biosimilar that was approved in the European countries, and then this was followed by other biosimilars and indications, and then in 2010 United States of America followed the same path that was followed in Europe. And luckily in Saudi Arabia in 2015 we had again the first biosimilars that were approved and launched in the country. Following that, we had the first guidelines on the biosimilar that was produced and prepared by the Saudi Food and Drug Authority, and then following that there was also a Saudi Society for Rheumatology initiative assessing the perception of rheumatologists with regards to the use of biosimilars in Saudi Arabia. So this is the guideline on biosimilar products that was prepared and issued by the Saudi Food and Drug Authority. And this is a study that was conducted by our colleague, Professor Muhammad Umair, in which he assessed the perception of biosimilar biologics and non-medicinal prescription switching among rheumatologists. This was like an initiative by the Saudi Society for Rheumatology. What was noted in this study that were like up to 60 to 70% of practicing rheumatologists, they had actually a good perception with regards to the biosimilars, and they were willing to switch their patients from like an originator medication to a biosimilar medication whenever there is like, a possibility of that, or if there is a demand by the authorizing, authorities. Now, moving on to the second part of this presentation, which is with regards to the interchangeability in biosimilars. So what is meant by interchangeability? So basically, interchangeability is either, switching or substitution. So, for example, if you have a patient who is on an originator A, for example, so switching that patient to biosimilar A, so this is called switching. Or, for example, you're simply, but this is because of like a reason, this is because of like, a medical reason. Substitution is basically that you are, changing the medication, the originator, to a biosimilar because of the either, the practice of dispensing one medicine in place of another without consulting the doctor. So to give you an example of, I think we have all seen that, especially in the Ministry of Health, hospitals, that, for example, our patients were on adalimumab reference medicine, and then all of a sudden you notice that patients were receiving like a different medication or a different pen or a different preparation. Basically, it was the same medicine, so it was, without consulting the physician. On the other hand, substituting a patient, from one medicine to another. So this is, for example, if your patient is on an anti-TNF-alpha inhibitor, such as, for example, golimumab, and then all of a sudden this medication goes out of the market because the Ministry of Health decided to stop having like this medicine into the shelves of the Ministry of Health. So then switching this patient from an originator medicine to a biosimilar, this is called, like switching. So both are, are things that are under the terminology interchangeability. Now, again, the European medicine agencies, incorporated and adopted this concept, and they clearly state, if you look at the two sentences that are highlighted in yellow at the bottom of this slide, that once a biosimilar is approved in the European countries, then it's, interchangeable. So this is also applied now in our, country through the different, healthcare sectors that we have in the country. Now, the third part of the presentation is concerned with regards to the translation of totality of evidence into clinical practice. So what is meant by, totality of evidence? So totality of evidence means that utilization of all the, resources that are available with regards to the analytical, non-clinical, clinical evidence that can tell you that this medicine is, or biosimilar is as good as the originator. And this should be like a stepwise, approach that will convince then the authorities to be, comfortable in prescribing the biosimilar medication. So if you look into the sentence, so again, totality of evidence, as I just mentioned, it's a stepwise, approach that uses the analytical, clinical similarity between the originator and the biosimilar in an attempt to, assess the similarity and for possible like interchangeability as well. Now, what happens sometimes that we, when we prescribe a biosimilar to our patient who was, receiving an originator, and then patient goes home with this biosimilar, and then all of a sudden he, finds like a different, package, a different pen, a different color, then patient will be having, some sort of like psychological perception that this medicine might not be like the same, or it might not be working. So it's basically the opposite of placebo, where our patients have negative, expectations on a medication that has not yet been, utilized or used by them, which is called a nocebo effect. And it's very important to address this issue with our patients, because this really decreases the rate of rejection, the possible, nocebo-related anticipated side effects in our patients. Now, this is probably the same that I was just talking about. So let me walk you through a few clinical cases from the practice at Noor Specialist Hospital in Mecca. So this is the first case, Abir, who is a 32-year-old woman from Saudi Arabia. She works as an assistant. Her history started in October 2019 when she presented with seropositive rheumatoid arthritis, who was initially managed with methotrexate that was started at a dose of 10 milligram and then maximized to 20 milligram over like 2-month period, as well as folic acid. 3 months into her treatment, she was still showing active disease, or sorry, 1 year into her treatment, because this is where like we had the COVID-19, so we were not able to follow up with our patients. She was continuing to see active disease. So at that time, adalimumab originator was added into her treatment regimen. Then from April 2021 to January 2022, so almost like 15 months, we continued to see this patient like on regular follow-up appointments, where she was like continuing to show us a status of the disease that was consistent with remission. And she was on adalimumab reference as well as methotrexate and folic acid. This changed into June 2022 when she presented again for like a routine follow-up, and she would tell us that she received a different pen, adalimumab. It's not the same. That was Hyrimoz, because in Ministry of Health we had adalimumab Hyrimoz biosimilar that was introduced into the Ministry of Health pharmacies in in January 2022. She was using it for over like 3 months before she presents to this follow-up, and she was noticing that nothing has changed in her disease, so she was continuing to be in remission. So we just reassured her. We conducted like a very quick education and counseling that made her like feel comfortable to continue using this medicine. The last time she was seen was in November 2022, where again she was continuing to be in remission, and that was really reassuring. The second case, again from the practice, it's for a patient who is a 55-year-old woman named Amina. She's from Yemen and she works as a housewife. Her history started in December 2022, again 21, where she again was diagnosed with seropositive rheumatoid arthritis with high inflammatory markers, as well as high disease activity. Again, we started her on methotrexate, folic acid, and prednisone with a quick taper. Almost like 2 months into treatment, she showed mild improvement with mild improvement in her DAS28 score as well. We increased the dose of methotrexate to 15 milligram, and we continued the rest of her treatment. After 3 months, she presented again and was showing clinical as well as radiological evidence of an active disease. And at that time, adalimumab Hyrimoz was added into her treatment regimen. She presented for follow-up in June 2022, where she was showing significant improvement in her clinical as well as radiological aspects of her disease, and we decided to continue her on adalimumab Hyrimoz. The last time she was seen again a few months ago, where she was showing a disease status that was consistent with remission. So this clinical practice is basically based on an evidence that comes from this randomized clinical trial. It is named ADMIRA, which was a multi-center randomized double-blind comparator controlled confirmatory study in patients with moderate to severe rheumatoid arthritis. So patients in this study were randomized either to receive adalimumab Hyrimoz or reference adalimumab for our total period of 12 weeks, which was like the first phase of the study. And then patients in the adalimumab Hyrimoz were continued to be on adalimumab Hyrimoz. However, patients in the reference adalimumab, which are represented here in blue, were switched to adalimumab Hyrimoz after the conclusion of the first week or the first phase of the study. The study was continued for a total of 48 weeks. Now, the primary endpoint of this study was to assess the mean change from baseline in DAS28 CRP scores over 12 weeks. And the secondary endpoint, as you can see here on the right side of the slide, was to continue to notice this change in the DAS28 CRP over a 48 weeks period, which was the second period of the study. Now, as you can see here, that there was clearly no significant difference between the changes in the DAS28 CRP scores in patients on adalimumab Hyrimoz, which is represented here in orange bar charts or bar graph compared to the reference adalimumab, which is presented here in blue. The same thing, was noted in with respect to the side effect profile in this patient, where you see that there were no statistically significant differences in the adverse events between both groups. With regards to the immunogenicity, which is the ability of a biological medication to activate the immune system to the extent that it is able to produce anti-drug antibodies as well as neutralizing antibodies, you can notably notice here that the immunogenicity profile was matching, and there were no differences between adalimumab Hyrimoz compared to adalimumab Humira or reference adalimumab in this study. Again, quality of life was almost different, so there were no changes with respect to facet or fatigue or the health related quality of life, and overall adverse treatment related adverse events were like almost similar in both study groups. Moving on to the last few slides of this presentation, which is concerned about the real world evidence that we have in this field. So this real world evidence actually comes all the way from the north, from Denmark, where they had a nationwide observational study called DanBio. This study studied the effectiveness and safety of adalimumab, biosimilars, in patients with several autoimmune inflammatory rheumatic diseases. So what is happening, or what has happened in Denmark, it also is happening now in Saudi Arabia, especially across like the Ministry of Health hospitals. So there was like a mandatory switch of all patients from originator to biosimilar for cost saving, and this is what's really happening in Ministry of Health in Saudi Arabia as well. This is a very massive registry where they have like more than 50,000 patients. Approximately 1,500 patients were eligible to be enrolled in this study. Out of them, like 1,300 patients were switched to adalimumab biosimilar, and 623 patients were on Sandoz adalimumab biosimilar, because we know that we have other like adalimumab biosimilars other than Sandoz. So the primary endpoint was the rate of retention in these patients. So basically what is meant by the rate of retention is that, so for example, after 1 year, how many of those patients who were on adalimumab biosimilars were continued to be on adalimumab biosimilar and did not require either escalation of treatment or changing of the treatment to another class of action. And there were also some secondary endpoints. So as you can see here, that approximately 90% of patients after 1 year, they were maintained on the adalimumab biosimilars that were started in these patients after like the switch. And 92% of Sandoz adalimumab biosimilar patients were maintained on the same treatment. Now, if you look at the disease remission at 6 months across like the several rheumatic diseases that these patients were treated for, so at the left side of the slide you see rheumatoid arthritis, you see psoriatic arthritis patients, and you see also patients with ankylosing spondylitis. And if you look at this forest plot and the line of no effect, you see that all the lines are moving towards the right side, with results that are represented in blue, which indicates that disease was maintained to be in remission in these patients in significant percentages. And as an overall, you see that up to 56% of patients were exhibiting remission rates that was measured by DAS28 as well as ASDAS in patients with ankylosing or axial spondyloarthritis. And again, there was no changes in the disease activity from switch to 6 month post-switch for patients who were maintained on Sandoz adalimumab. And as you can see here, that the disease activity measures that are here in the left side of the slide, you don't see changes in patients across different disease activity measures in the different diseases such as rheumatoid arthritis, psoriatic arthritis, as well as axial spondyloarthritis. So ladies and gentlemen, if you allow me to summarize the slides that I presented, so I will say that biosimilars allow major cost savings and may increase patient access to biologics. prospective data in RA and psoriatic arthritis demonstrate high comparability between biosimilar and originator anti-TNFs in terms of efficacy and safety. Rates of immunogenicity with biosimilar and originator anti-TNF alpha inhibitors are similar, and real-world evidence supports the efficacy and safety of switching from an originator anti-TNF to a biosimilar anti-TNF. And I would say that in a neurospecialist hospital, we have approximately more than 100 patients who were either switched from an anti-TNF alpha inhibitor to Sandoz adalimumab, or they were, started on Sandoz adalimumab as an initial treatment. And we continue to see, reassuring and promising, disease statuses in these patients. And I would like to thank you for your kind attention and listening. Is there any question that we can take one question? No? Thank you. في سؤال؟ تفضلي دكتورة. IT team, can you help us with the microphone for the doctor? Or if you want, you can just, Okay, so I think physicians are not the right people to be asked about pricing. However, we have our colleagues from Sandoz here. So if I may remember that the originator adalimumab costs between 5 to 6, 1,000 riyal per month for 2 doses. I think the price is 50% less in Hyrimoz, right? صحيح? Colleagues from Sandoz. ارفعوا صوتكم. أنا ما أفهم لغة الإشارة. ها؟ 50%.
It's 60% less than the original.
يعني كم الكوست حق الأدليموماب هايريموز في الشهر الواحد؟
We can say it's for sure more cost efficient, but for more details you can visit Sandoz booth.
Okay, perfect. Thank you.
شكرا دكتور وليد حافظ. مباشرة إلى الجلسة الأخيرة من مؤتمرنا التاسع لأمراض الروماتيزم برئاسة الدكتور منصور سويملي والدكتور ياسر باوزير.
جلسة إيش والناس
Assalamu alaikum wa rahmatullahi wa barakatuh. I would like to thank Dr. Hanan Al-Rais as well as the organizing committee for giving me and Dr. Mansour this opportunity today to be the chairperson for our last session, which is the radiology session. Our next speaker will be Dr. Khalid Al-Ismail. He is a consultant radiologist from King Faisal Specialist Hospital. He's the director of scientific committee of MSK Radiology at Saudi Fellowship Program. As well, he is the founder and the former president of Arabian Gulf Society of Skeletal Radiology, and he is the vice president of the Asian Musculoskeletal Society, as well as a member of the committee there. Thank you, Doctor. Please.
ناخذ البرزنتيشن رقم 1. طيب، بسم الله الرحمن الرحيم. اللهم صل على محمد. اللهم علمنا ما ينفعنا وانفعنا بما علمتنا وزدنا علما. شكرا جزيلا للإخوة والأخوات في الجمعية لإعطائي هذه الفرصة. حقيقة ممتازة جدا أن ألتقي بالإخوة والأفاضل في rheumatology. What I did in a matter of 30 minutes, definitely you cannot cover the radiology aspect of rheumatological diseases. But the things which is really good, that we share some sort of clinical cases with interesting outcomes. I'll present 7 patterns of diseases. Hopefully we can get maximum benefit. This is a 65 years female, low back pain, joint pain, swelling, skin lesions, brain infarcts 3 years ago. So what we are really seeing, في عندنا أو كان دوي نشر على هذا ولا إيش؟ ها؟ ما يشتغل الماركر؟ طيب على الأخضر وهنا بعيدة على هذه أيوة وهذه هنا طيب يلا تخيلوا معي ما عندكم مشكلة يعني اللي يكونوا تتخيلون. What we are seeing, as a matter of fact, this is a lateral lumbosacral spine. You can see the last disc space, which is really sclerotic. The disc space is narrowed. The end plates are sclerotic as well. We can see spikes of osteophytes as well. In 2 or 3 levels, we have almost sclerotic vertebra. And this is the whole picture of this patient. So if we go for CT, we have the same in the red arrow, a significant reduction of the disc space, sclerosis of end plates, marginal osteophytes or erosion-like changes. Higher up, you have a block of dense vertebra, which is really squared. On the sternoclavicular joint, you can see both joints are eroded with sclerosis. So what we are having in this case, as a differential diagnosis, we have a long list of pathologies. Osteomyelitis, discitis, osteosarcoma versus Ewing sarcoma, especially if it is going towards the osteoblastic activity, sclerosis, Ewing sarcoma and the clavicle, Paget disease as a squaring dense vertebra, metastasis, osteitis condensus of the clavicles, and Poems disease, which is sclerotic form of multiple myeloma. This patient is Sappho syndrome. Sappho, we know that it is pustulosis, synovitis first, acne, pustulosis, hyperostosis, and osteitis. This is one of the important diseases where you should take care of it. If the patient has back pain, have also the skin lesions, pustulosis, and might have also cranial infarctions because of the pachymeningitis, hyperplasia, and this causes intracranial arterial occlusion. So just keep these in mind as a separate entity and disease. Case number 2, 37 years male, known an old JIA, referred to an adult RA, progressive 5th finger drop, and now having a similar symptom starting on the 4th finger. What is the diagnosis? What we are really having in here is that most of the findings or changes are occurring in the proximal joints, especially in the radiocarpal joint and distal radio-ulnar joint. Destruction of the joints, secondary ankylosis, fusion of the joints and the carpal bones, erosions at the carpo-metacarpal joints and metacarpophalangeal joints, which are more proximal, where you expect the same thing happening in the case of JIA or RA, inflammatory arthritis. This patient had a clinical examination of dropping 5th finger, which is towards the ulnar side. If you see this radio-ulnar joint, it's almost subluxed, eroded, nothing remaining from the articular surface. And the distal radio-ulnar joint distance is widened at the same time. So what shall we do? Definitely we'll go for clinical examination. We can see that the 5th finger is dropping. MRI examination. On your left-hand side, you can see that there is the arrowhead. This is the fourth compartment where the extensor tendons are located for extensor digitorum tendons, which is compartment number 4. Compartment number 5, which is the arrow, which is containing the extensor GGT minimi, which is showing it stretched, torn, and the one which is down, that is the compartment number 6, extensor carpi ulnaris. So in this case, we have subluxation and tear of the compartment number 5, which is mainly extensor digiti minimi tendon. So what is this disease? This is Vaughan-Jackson syndrome. So what is really happening in these cases? There's a tear, disruption of the extensor mechanism by disruption of the extensor tendon itself, leading to flexion deformity and inability to extend the fingers. And this starts from the ulnar aspect going towards the index finger. So from compartment number 5 towards compartment number 3 and 4. Other causes should be significantly excluded, especially those with the dislocation subluxation, posterior interosseous nerve injury or palsy, which occurs around the proximal radioulnar joint. So any entrapment of that nerve would lead to wrist drop. So we should be very careful in these cases. What can we do in these cases, management-wise? If we diagnose this patient, definitely he needs surgical intervention, relocation of the tendons, or tendon transfer might be the best way to go. This is just coming inside these cases because we don't need to miss the basics of radiology in rheumatology. A, B, C, D, E, S. If you are going to evaluate any radiological cases on plain X-rays, please do not forget A, B, C, D, S. A, alignment. B, bone quality. C, cartilage or joint spaces. D, distribution, is it proximal or distal? Is it unilateral or bilateral, symmetrical? Erosions, positive or negative? And then the soft tissue involvement. Is there any soft tissue swelling? Is there any calcification, etc., etc.? So these are one of the most important 6 items you should evaluate in every case. This is a case which is really showing nothing except just a minimal fullness of the radial aspect with at the scaphoid fatty plane, which is really mildly displaced, and also the ulnar aspect fullness with soft tissue. It's very, very subtle. If it is me during the heavy workload, doing the X-rays, normal. Clinically, the patient is not normal. MRI. You can see the difference between the MRI sensitivity in showing the soft tissue pathologies compared to plain X-rays. So you can see that significant pannus formation with erosions around the wrist joint where we fail to see them or to show them on the plain X-rays. This patient had arthritis or synovitis protocol. That means we inject gadolinium or contrast for enhancement. So without contrast enhancement, these masses are there. But what else after contrast enhancement? You can see that Even the extensor compartments are involved, and also the flexor compartments are involved with significant enhancement compared to the left-hand side image. So we have the right side hand image, which is the contrast. You can see the carpal tunnel enhancement, and this patient is diagnosed to have rheumatoid arthritis, pannus formation, synovitis, involvement of the extensor and flexor compartments with the compartment, which is with the carpal tunnel syndrome. So we should know what are we really dealing with to treat these patients. Ultrasound nowadays available in every institution. Thank you for the thanks for the companies which are really supporting these. But we should be very careful in assessing these patients with ultrasound. A case has done the ultrasound of the distal forearm. Dorsally, the patient had sort of swelling. What we are seeing now is, if you see it, C2, that means the compartment number 2. The compartment number 1, which is decurvent tenosynovitis, normal in this patient. Compartment number 2, which is extensor carpi radialis compartment, longus and brevis. Compartment 3, which is extensor pollicis longus tendon, passing above the compartment 2. And this is what we are seeing in this patient. It is inflammation, synovitis, fluid collection, exactly at the time, at the location of intersection. So this is a case of distal intersection syndrome. Those patients who are using their hands in rolling, housekeepers, pushing trolleys, they might have these syndromes. So this is a tenosynovitis, probably partial tear might occur, lump, painful, inflammatory arthritis picture. So this is a treatable condition with ultrasound-guided injection. How can we differentiate between the decurvent tenosynovitis and the distal intersection syndrome? As I told you, that decurvent syndrome is in compartment number 1. The distal intersection syndrome is at the intersection between 3 and 2. Case number 4, 56 years female, neck pain for 20 years. Plain x-rays of the neck, inflection and the neutral position. It's a ABC. You check as rheumatologist, you check about retrodental or retinoodontoid process distance, which is atlantoaxial space. If you see it in the flexion, it is more wide. So if it is more than 3 millimeters in adult patients, this is positive for widening and pathology. If it is more than 5 millimeters in pediatric age group, this is abnormal for the distance. CT scan, you can see the erosions, destruction of the odontoid peg process with significant posterior bowing of the transverse ligament, and you can see it causing cervical cord compression. So it's very important in these cases that you don't miss such cases. So patients going to OR, rheumatoid arthritis, we should exclude any laxity or pannus formation in the atlantoaxial articulation. Case number 5, 19 years male, complaining of progressive bone pain for the last 15 years. That means at the age of 4, he has those pains. Easily got fatigability, and this is his left leg. The abnormality here is that almost diffuse, heterogeneous, increased density or sclerosis. mainly involving the diaphysis of the ulna. There is no significant associated periusury action or ugly-looking periusury action. There is no associated soft tissue swelling. This patient had further evaluation, CT scan examination showing that the sclerosis involving the intramedullary aspect with expansion. The bone marrow is involved, bone scan showing the other side to be affected as well. So this one is the Camurati-Engelmann disease. So if you see such cases, we should have also differential diagnoses. So differential diagnoses in young patients, you should not forget about CRMO or osteomyelitis. Last year, we spoke about CRMO or CNO, so it's very important to include it in your differential diagnosis. Case number 6. 53 years female, lesion in the first or big toe, painful with swelling. So what we are seeing here, that coronal or long axis T1, T2. The most important one is the coronal long axis in the right-hand upper row. What we are seeing here is bright signal intensity around the first metatarsophalangeal joint with internal low signal fillings. You should take care about this one. X-rays, we'll go back to X-rays. What we are seeing here, in the right-hand side, long axis or oblique sagittal or lateral X-ray showing small speckles of calcifications. So what is this? Is there any osteopenia? No. Is there any erosions? No. Is there any dislocations? No. So this patient is having differential diagnoses. Gouty arthropathy, no erosions, no destruction. And most of the time it appears as a dense soft tissue, which is the tophaceous type. OA, probably secondary. RA, no, everything is against RA, which is bone density, no erosions. Synovial osteochondromatosis. This is a synovial lesion with no significant erosions with evidence of calcification or ossification. If you have synovial osteochondromatosis with secondary degenerative changes, this is a secondary synovial osteochondromatosis. If you have no evidence of degenerative changes, this is a primary case of synovial osteochondromatosis. والشيء بالشيء يذكر. We can differentiate between gouty arthropathy, like this one, typical picture with overhanging margin edges erosions with normal or slightly reduced bone density, and lumpy-bumpy disease. Lots of lumps around the joints. And this is the dual energy CT scan examination for gouty arthropathy, and it is diagnostic. Pathognomonic features if you do the monosodium urate mapping. A similar case, but no calcification, erosions, apple coring of the femoral neck, apple coring. You can see indentation from the inferior aspect, soft tissue, swelling involving the joint with secondary effect and erosions on the femoral neck. No ossification. This is the primary synovial chondromatosis, no osteochondromatosis, but this one is chondromatosis. Other differentials, PVNS, pigmented villonodular synovitis, hemophilic arthritis, and RA. This is an interesting case. والرقم 7 حنا نتبارك فيه. And this is the last case. 56 male patient complaining of low back pain. On clinical examination, this patient has dark pigmentation over the photo-exposed areas. This is the X-ray. Anyone? تفضل يا دكتور. الكابتونيوريا اعتمادا على الهيستوري على الاكس راي. Okay, about the pigmentation. Okay, excellent. خلاص أنا أمشي البيت ما تحتاجون. لكن why I brought this case, I can omit the pigmentation issue. A typical appearance like ankylosing spondylitis. The only difference in this case, I'll show you the X-ray of the dorsolambosacral spine, lateral and AP. Every ligament is ossified or calcified. Fusion or ankylosis of sacroiliac joints bilaterally symmetrically. The only difference between this case and the ankylosing spondylitis is the intervertebral disc space calcification. So if you see calcification of the disc itself, this is not a characteristic feature for ankylosing spondylitis or inflammatory arthritis. So this one is alkaptonuria or ochronosis. So we should be knowing the small differences between similar diseases, different manifestations. Thank you very much.
Thank you, Dr. Khalid, for this nice presentation. I would like to invite the attendee now for questions. If you have any question for Mr. Speaker.
أحسن شيء الواحد يكون آخر واحد والناس رابطة إن الشنط حقتها وتمشي.
Okay.
طيب. عندك سؤال؟ قول سبحانك اللهم وبحمدك أشهد أن لا إله إلا أنت أستغفرك وأتوب إليك. شكرا للجميع.
Thank you. So we conclude this session. Thank you for attending this session, and I would like to thank Dr. Khalid also.
شكرا دكتور خالد. دكتور ياسر باوزير بعد شكرا لك. بداية التكريم لدكتور ياسر باوزير رئيس الجلسة 11 والأخيرة من مؤتمرنا التاسع لأمراض الروماتيزم. ثم تكريم المتحدث الرئيسي في هذه الجلسة الدكتور خالد الإسماعيلي. السادة والسيدات، ستبدأ الجلسة الختامية بعد لحظات من الآن. نشكر لكم انتظاركم.
السلام عليكم ورحمة الله وبركاته. الرجاء البقاء كذا دقيقتين عشان نبدأ جلسة الختام بإذن الله تعالى. حيكون طبعا فيها إعلان الفائزين المتسابقين اللي هم الفيرست والسكند والثيرد في الابستراكت سبمشن اليونج انفستيجيتور بإذن الله.
السادة والسيدات، نشاهد وإياكم الآن عرضا مرئيا يلخص أيام وجدول أعمال المؤتمر السنوي التاسع للجمعية السعودية لأمراض الروماتيزم. وأبارك نجاح المؤتمر، ويسر اللجنة المنظمة أيضا في ختام المؤتمر أن تعلن عن الفائزين بمسابقة عروض الشباب التي تم إقامتها على هامش مؤتمرنا التاسع للجمعية السعودية لأمراض الروماتيزم. هم ثلاث فائزين. نبدأ بالثالث، الدكتورة فاطمة الخرص، ثم الفائز الثاني الدكتورة عبير الخضير، والفائز أو الفائزة أيضا بالمركز الأول كلهم بنات ما شاء الله الدكتورة الشهد الأنصاري. مبروك لفاطمة وعبير وشهد. والآن إلى الجلسة الختامية مع الدكتورة حنان بنت محمد الرئيس.
طبعا الأول والثالث ما هم موجودين، سافروا، فبإذن الله بعدين توصل لهم إن شاء الله شهادات. نشكرهم جميعا، الحمد لله والشكر لله. زي ما أنتم عارفين تقدم أكثر من 50 ورقة بحث وتم قبول 29. You know, we want to encourage the research, especially for young investigator, and this mainly for the young investigator. The first and the third was from the pediatric. So we are very thankful for the content for all of them actually. We are proud that most of them they are students, so they are very excellent. So this is a medical student, the one who received the second, and I think even the first one, Dr. Prof. Suleiman, the first, can you come please? Because the first research and the title, because I don't know about the title of the research of the first and the second one was about outcome of pregnancy in rheumatic diseases, and the first and the third, Prof. Suleiman will mention the title of the research.
We are proud, both of them from our section at King Faisal Hospital. The first abstract was about genotype, phenotype cohorts of interferonopathies. I think this is the largest cohort so far, at least in the region. The third abstract was comparison between monogenic and sporadic lupus. Again, it was a large cohort.
طبعا أيام عدت سريعة، 4 أيام وقبلها سنة من التحضيرات. سعدنا كثيرا بوجودكم جميعا. احنا نسمي مؤتمرنا السنوي هو عرس الجمعية، اللي نلتقي فيه بجميع الأعضاء من داخل وخارج المملكة. دائما يكون معنا جداد، يعني ناس جداد، وهذا شيء يعني جميل. حرصنا هذه السنة مع أنه كان في عندنا كل الفاسيلتي عشان يكون معنا زوم ميتينج، لكن حرصنا أنه يكون حضوري عشان الكل يجي. عدد، طبعا احنا من 2010 سنويا المؤتمر، نظمت المؤتمر 2010. كان عدد الروماتولوجيست يعني في السعودية بين البيدياتريك والأدلت كان ما يقارب 100. أول مؤتمر نظمناه كنا خايفين من الحضور، فوسعنا وسوينا الأكسس إن يكون more than one project للروماتولوجيست فور نون روماتولوجيست، وكان الحضور في هذيك السنة ما يقارب 300. السنة ممكن الإحصائيات، السنة تعدينا 1000 في الريجستريشن، حضوريا في عند البيدياتريك كان زي ما انتم شايفين هنا 800 توتال. هو طبعا مور ذان 1000 لما نحسب الإعلام والمنظمين وغيرهم والنون روماتولوجيست. بالنسبة لورش العمل كانت 17 ورشة عمل، كلها ما شاء الله كانت ناجحة. الالترا ساوند كنا مسوينه لما يقارب 30 كانديديت، ورفعنا الاستيعابية بسبب كثرة المسجلين، فكانت في تقريبا 10 ستيشن، والكل الحمد لله والشكر لله كان يعني مبسوط من الكونتنت. حرصنا هذه السنة إنه يكون معظم المتحدثين من السعودية ومن الخليج، على أساس هذه فرصتنا وفرصة باسم الجمعية. طلبنا من جميع الروماتولوجيست في السعودية إنهم يقدموا، زي ما أنتم عارفين عندنا أعضاء الجمعية الآن وصلوا إلى أكثر من 400 طبيب روماتيزم في السعودية، ما بين أطباء روماتيزم أطفال وكبار، وكثير ما شاء الله عندهم سب سبيشاليتي واكسبيرينس، فصار صعب إحصاء. وحتى على اللجنة العلمية حرصنا إنه اللجنة العلمية يكون فيها من كل منطقة، على أساس يقولوا لنا بكل جديد، كل طبيب جديد واختصاص موجود. ولكن بالرغم من هذا ما أكيد إننا في ناس مثلا يقولوا ما دعوتونا أو شيء، إحنا بالعكس زي ما انتم شايفين عدد المتحدثين ورؤساء الجلسات وصلنا 130. الغرض انه الكل يشارك، حابين من الجميع اللي اي احد جديد على الجمعيه يرسلوا لنا CV، اي استفسارات، اي اقتراحات لتطوير المؤتمر. احنا دائما على الرحب والسعه. احنا الغرض دائما كل سنه يكون افضل من اللي بعدها، ودائما نحب الكل يشارك. عشان كذا احنا طلبنا، إذا كنت تفتكروا أعلنا كلجنة علمية، أعلنا كذا إعلان، اللي عنده بروجكت معين يرسل مع كلير أوبجكتيفز وCV على أساس نساعد حتى في اختيار الجدول. أشكر اللجنة العلمية على اختيارهم المواضيع. طبعا أنتم عارفين إنه الثيم كان challenges and advance in RA because we used to face a lot of challenge. فحاولنا يكون معظم المواضيع تغطي هذا التشالنجز، ونشكر الله. يعني أتمنى إنه تكونوا استفدتوا، وإنه نكون دائما عند تقديركم يعني واهتماماتكم. أحب أشكر اللجنة المنظمة على مساعدتهم وعلى تنظيمهم معنا. أشكر الشركة المنظمة، أستاذ نزار معانا، عانى معايا شوية أن طلباتي كثيرة لكن حاولنا وحرصنا أنه نوصل لأحسن شيء، وما زلنا نأمل ونتطلع للأفضل. وبإذن الله تعالى السنة القادمة حيكون المؤتمر في الخبر في فبراير، كلكم إن شاء الله تكونوا موجودين معنا، ودائما إن شاء الله يكون أفضل والأفضل. الآن حابة نكرم اللجنة المنظمة واللجنة العلمية.
شكرا دكتورة حنان، جهود ملحوظة للجمعية، نسأل الله التوفيق للجميع، وندعو اللجنة كافة أعضاء اللجنة التنظيمية واللجنة العلمية، دكتور عبد اللطيف العنزي، دكتورة أمل الحارثي، دكتورة أشواق الحارثي، دكتور فهيد العنزي، دكتورة لينا الكبي، دكتور عبد العزيز الخلف، دكتور ماجد البرديسي، وإلى اللجنة العلمية دكتورة لجين أكبر، دكتور موسى العباس، دكتور نايف الغانم، دكتورة ريما بكري، دكتورة سلطانة عبد العزيز، دكتور وليد عبد الرب حافظ، والبروفيسور سليمان المعيوف، والدكتور حسين حلبي. شكرا جزيلا لكل من ساهم في إنجاح هذا المؤتمر، وشكرا للمنظمين ولكافة العاملين في اللجان. نسأل الله سبحانه وتعالى أن يوفقكم جميعا، وعلى أمل أن نلتقي بكم في النسخة القادمة من المؤتمر السنوي للجمعية السعودية لأمراض الروماتيزم. نستودعكم الله، والسلام عليكم ورحمة الله وبركاته. ندعو الجميع إلى المنصة من أجل الصورة الجماعية على رأس الدكتورة فهيدة العنزي.
دكتورة فهيدة ما أخذتي
تفضلي.
في الختام. طبعا احنا لسه كنا بعد ما كرمنا كنت حابة أقول إنه خلال الورش العمل تم تقرير 6 برامج اللي هي بحثية هنشتغل عليها مع في الريجستري في الروماتويد وفي اللوبس، وحنرسل لكم إن شاء الله إيميلات للمشاركة. طبعا شكر كبير كبير جدا للدكتور فهيد العنزي رئيس المؤتمر. احنا كلنا كنا الحمد لله، سواء اللجنة العلمية، اللجنة التنظيمية، مجلس الإدارة، كلنا كنا سوا في التحضيرات، وكنا الحمد لله هذه السنة مرت نجحت لأنه كلنا كنا سموث والكل كان متعاون. ما يعني ما نقدر نقول واحد عن الثاني، ما شاء الله كلهم كانوا متعاونين. يعني أسأل الله التوفيق والنجاح، وإن شاء الله بإذن الله تعالى المشاركة من جميع أعضاء الجمعية ومن الجميع. طبعا أشكر كل رؤساء الجمعيات الخليجية. معنا الدكتورة سمر، جاءت الدكتورة فاطمة رئيسة الرابط ورئيسة جمعية الكويت، معنا رئيسة جمعية البحرين، كان معنا كمان من الإمارات، كلهم شاركوا. أشكرهم جميعا. كان في عدد حضور مميز من الخليج، من الإمارات، من الكويت. فالحمد لله والشكر لله. بإذن الله تعالى السنوات القادمة كلنا سوا، فياريت الجميع يجي نعمل صورة جماعية باللي بقوا، بما فيهم الشركة المنظمة طبعا. فأشكركم جميعا وإلى لقاء قريب. شكرا لكم.
الزملاء الكرام، الآن صورة جماعية لجميع الحضور، من يرغب يأخذ صورة فمرحبا به. هذه صور تذكارية بإذن الله تعالى، إن شاء الله سوف ترسل لكم بإذن الله لاحقا، ولكن بالفعل إن حريصين إنه الجميع يعني يصور معنا في هذه المناسبة السعيدة. الشركة المنظمة